like, I'll tell you where the mistake is. This you should not do. You have put only your name, as if you are the only person who has done the study without any guidance, no help from anyone.
Okay, sir.
Okay, so your co-authors, your guide name should be there. Okay, here it's okay, fine, but this is not your only presentation. You are going to present in other bigger forums, so your persons who have contributed should be there. Yourself, your guide, your colleagues, whoever has done, be part of the study, just like it is pre-publication. So whoever are going to be there in the publication, their name also has to be here.
Okay, sir.
Okay. We are only putting your name, it looks like to us that you only yourself has done the work without help from anyone, without guidance from anyone. I don't think which is correct. Okay, so you should put all authors' name. Okay, including your guide. Anyway, we have come to the end.
Thank you.
Of the pre-paper session.
Hello. There's an announcement. All the PGs who have presented paper now, we are requested to come to the photo booth for the certificate giving ceremony. All the PGs who have presented paper now. So please come to the photo booth. M. Hematology, Professor, Department of Medicine, Dr. T. Brojan Singh, DM, Nephrology, Professor and Head, Department of Nephrology, RIMS, Dr. Khetrimayum Manglim Singh, Senior Consultant, Dr. M. Ratan Kumar Singh, DNB, Neurology, Professor, Department of Medicine, and last but not the least, Dr. K. Romeo, Professor, Department of Medicine, RIMS, would like to request your kind presence on the dais and chaired the first scientific session. A very good morning, respected chairpersons. Now I would like to hand over the mic.
A very good morning, and now this one. Yeah, I got the topic now, and for the past this one topic, MASLD, realization as a diabetic complications. The speaker is Dr. Maibam Bobi. He is Associate Professor, JNIMS, and DM Hepatologist. I think Bobi will do the justice. So I call upon Dr. Bobi to present his presentation. Thank you. Bobi, please.
Good morning, everyone. So, the topic of my today's discussion will be a muscle, which is a realization of a complication of diabetes. So, we all know that the spectrum of the etiology of chronic liver disease is changing for the last decade. So, with hepatitis B, C coming down, and fatty liver, especially muscle and alcoholic liver disease increasing in every parts of the world. So I'll just try to discuss, the agenda will be introduction, then diabetes and muscle relationship, how to diagnose, risk stratification, management, and summary. So we all know that muscle is a type of the steatotic liver disease. So any steatotic liver disease can define as when more than 5% of hepatocytes shows macrovesicular steatosis, which may be proved with biopsy or imaging, with the presence of one or other cardiometabolic risk factors. So the global prevalence is around 25 to 30%, but there is geographical variations with some high areas like these red areas. Latin America, 1 minute. Okay. So this Latin American and this Middle East countries having the high prevalence, and it depends also on the patient population. This profile having the high prevalence among diabetes and obesity. So if we look into the muscle spectrum, so it has the muscle steatotic liver disease isolated, which is followed by the mass. So majority of the patient, they remain in the muscle stage, and only around 25 to 30% they'll go into the mass stage, which is characterized by the inflammation, fibrosis, and leading to cirrhosis and the complications like decompensation and the HCC. So to look into the cardiometabolic risk factors, we have these risk factors like BMI more than 25 kg per meter square, which is 23 for Asian population. Then we have this fasting blood glucose and this postprandial blood glucose, or any patient which is non-case of diabetes or which are on OHA or insulin. Then we have this blood pressure, then plasma triglyceride level and HDL levels. So likewise, the criteria are almost the same with the pediatric criteria, except for the BMI, which is taken as a percentile. So how to approach the SLD patient, the steatotic liver disease? So it has many etiologies, as I mentioned. So whenever any steatotic liver disease comes, so our first question will be whether there is presence of any cardiometabolic risk factor or not. If it is yes, then we have to ask for the history about the alcohol consumption, the amount of the alcohol consumption. So if there is alcohol consumption is not there, then we classify those steatotic liver disease as the muscle, which may be followed by mass. But in case when there is no any alcohol intake, or there is alcohol intake, then we classify the steatotic liver disease into overlap of ALD, metabolic and alcoholic, or if the alcoholic level is significantly increased, more than 50 gram or more than 60 gram in case of female, then we call as alcoholic liver disease. Then we have this cryptogenic SLD, then hepatitis C virus related, drug-induced liver injury related, Wilson disease related steatotic liver disease. So majority of the steatotic liver disease is because of the muscle and alcoholic liver diseases and overlap of the MET-LD. So what is the relationship between muscle and diabetes is that muscle and the diabetes, they share many pathophysiological features. Most important is the insulin resistance. If we look into this picture, the diabetic patient have insulin resistance, which causes the adipokine. There is the defect in the adipokine, various secretion of the adipokine factors, leading to the lipotoxicity, then fatty acid accumulation, leading to the muscle. Then it also, on the other hand, if you look into this side, accumulation of the high fat diet that increases the de novo synthesis of the free fatty acids. This leads to the accumulation of free fatty acids, leading to the mitochondrial injury, leading to the inflammation, so ultimately leading into the insulin resistance. So all these factors, they combine together and they lead to the development of the muscles. So we know that the muscle and this diabetes, they have a close relationship. As we look into this, there is a synergistic interaction between this TDM and the NFLD. So why it is important to recognize this association? Number one is there is high prevalence of the muscle among the diabetes. This was a study published in the 2023. They saw that the prevalence was 65% of muscle among diabetic patients. And this metabolic associated steatotic hepatitis, that inflammation was found in around 32%, and advanced fibrosis F3 and F4 was found around 15% of the diabetic patients. So again in October 2024, there comes one paper with the meta-analysis. So here shows the increasing pattern of the muscle among the diabetic patient. So this clearly shows that there is increasing trend of this diagnosis of the muscle among diabetes patient. As the diabetes is increasing, the diagnosis of the muscle is also increasing, and we also see the increasing trend of this mass, then significant fibrosis and advanced fibrosis. Everything is increasing. Now another second point is the impact of the muscle on type 2 diabetes is that muscle can be considered as a pre-diabetic condition. In this study, they found that this meta-analysis, 33 studies, they found that the hazard ratio for the development of this diabetes among muscle patient was 2.2, which was more correlated with the advanced fibrosis. So in the patient with steatosis, only steatosis, the hazard ratio was 2.4, and when the patient developed F2, F4, F2 to F4, then the hazard ratio was 2.69. So overall, the more is the fibrosis, more is the hazard ratio for the development of the diabetes among the muscle patient, which is also seen from this forest chart. Now, third is whether diabetes has any effect on the fibrosis progression or not. So this was a study done, and it was published in 2023. They saw that diabetes increases the fibrosis progression with a significant value we see here 0.005. So we have this no T2DM group and one T2DM group. So they compare. So we clearly see that those patients with this diabetes mellitus with muscle, their fibrosis progression was much compared to those patients without any diabetes. So what is the impact of this fibrosis, and what is the impact of this combination of diabetes and the muscle in the outcome of the patients? We see that diabetes and the muscle, NFLD, as I already discussed, they act as a synergistic reaction, they remain in synergistic bidirectional reaction. So diabetes increases NFLD, and NFLD increases the diabetes. So they causes the microvesicular and the macrovesicular complications. They also increase in the liver-related complications like this ascites, like hepatic encephalopathy, as well as the onset of the hepatocellular carcinoma. So how do we diagnose? Diagnosis can be divided into three parts. To diagnose whether the this steatosis is or not there, then we have for that ultrasonography, then we that fibroscan, MRI, and the CT scan. So USG and this fibroscan is widely available, and the problem with the ultrasonography is the sensitivity varies, and it depends upon also the operator also. Otherwise, it's a very good option. It is easily available, non-intervention type. And BCCT, this fibroscan, it is nowadays becoming one of the modalities for diagnosis of the steatosis. Then once the steatosis is diagnosed, then we have to see whether the inflammation is present or not. So AST, ALT is the most easiest way, but sometimes, most of the time, it does not correlate. It correlates only in 70 to 80% of the time. So remaining around 15 to 20%, we cannot correlate with the AST and ALT. Others are cytokeratin-19. Then with combination of the fibroscan with the AST. Then the most important part is the fibrosis. We have to see whether, look into the fibrosis stage. For that we have this FIB4 score, which is very easy to calculate. It's available online, anyone can do. So we have this FIB4 this scoring, then NFS score, then ELF test is there, fibro test is there. So out of his FIB4 is very easy to calculate, and NFS is also very easy to calculate. Then imaging wise, we have this fibroscan. Again, in fibroscan we look for the liver stiffness measurement, LSM. So these are the modalities for the diagnosis. So any patient with muscle, the diabetes mellitus should be surveyed, should be looked for the presence of the muscle. This is a very cumbersome diagram. So I just make it clear, easy. So once we have this diagnose a patient with the muscle, then what we have to do is that the risk stratification is very important. Risk stratification means we have to divide the patient into mild, moderate, and the severe groups. So here what we do is that we calculate the FIB4, which is less than 1.3, and NFS score less than minus 1.45. We call it as low risk. So the FIB4, it is for less than 65 years, but if the patient is 65 years, the lower limit can be taken as a 2. Then those patients with FIB4 more than 1.3 and up to 2.67, they are put into the intermediate group, and FIB4 more than 2.67, they are very high risk group. So they are usually they belong into the cirrhotic range of patient. So what we do is that those patients in the very low risk group, we can put the patient for follow-ups every 1 to 2 years, 2 to 3 years, depending upon the presence of types of these metabolic risk factors. Then those patients in the intermediate and the high risk patients, intermediate, then we look for the LSM. LSM less than 8, we call it as low risk. Again, we can go for the this follow-up of this patient. Then those patients with intermediate risk and those with more than 12 kPa, they belongs to the high risk group. This patient, they need to undergo the liver biopsy. Then according to the liver biopsy, we divide the patient into F0 to F1, F2 to F3, and F4 cirrhosis. This F2 to F4 patient or cirrhotic patient, this belongs to the very high risk groups, and this is what the risk. This is what we do for the risk stratification. So during risk stratification, it is very important to identify the F2 fibrosis, because F2 fibrosis is very, very important. So this is the phenotype which drives the liver-related mortality and outcome. Once patient reaches this F2 fibrosis stage, then liver-related mortality and outcome increases. Then there is also non-liver-related outcomes, mortality, cardiovascular events also increase. Now, once the F2 fibrosis develops, then the development of the hepatocellular dysfunction occur, then portal hypertension sets in, then there is less chance for the fibrosis resolution. Practically also, when we treat a patient, F1 patient, we can treat the patient with lifestyle modification, but once patient goes into the F2 fibrosis, it's very difficult for the lifestyle modification only. With that patient, we need the NEDS-directed treatment also. So another study, they found that fibrosis stage, but not the NEDS stage. NEDS predicts the mortality and the time for the development of severe liver disease. This was published in 2015. Here they compared those patients with fibrosis and those patients without fibrosis. So these are the patients with the fibrosis and these are the patients without fibrosis. So if patient does have NAS, a patient does have this steatosis without fibrosis, then outcome was better, and patient with steatosis or patient with MAS with fibrosis, the outcome was worse and it was similar. That means the fibrosis is the one of the most important factor rather than the inflammation or rather than the steatosis itself. And if you look into the this natural history, patient in F1 to F0 to F1 stage, they go into this decompensation over a period of 20 to 26 years. Once patient goes into the F2, there is a sudden change of 9.3 years from 22 to 26 years. So it takes only 9.3 years for the patient with F2 to go into the decompensation, and for only less than 1 year for those patients with F4 stage. So fibrosis is very important. That is what we look into while we do this risk stratification. Now, management approach is multidisciplinary. We have this gastroenterologist, we have this hepatologist, we have diabetologist, then we have nutritionalists. So this is a multidisciplinary field. Everyone has to be contribute in the treatment of this patient. Now, what are the modalities that we have? So we divide the patient into F0 fibrosis, F1 to F3, and F4 fibrosis, or which is cirrhosis. So lifestyle modification is recommended in every group of the patient. Cardiovascular risk reduction has to be done in every group of the patient. Diabetes care has to be done in every patient group, and especially in the F1 to F4 patient, we prefer those medication, diabetic medication, which has efficacy in the NAS. Then NAS-directed pharmacotherapy, it is done only in the F1 to F3 group of the patient. No NAS-directed pharmacotherapy has been recommended till now in F4 fibrosis, although there are certain single-center these studies that I am coming later on. Once the patient goes into the F4 fibrosis or cirrhosis, then hepatocellular carcinoma screening, varicose surveillance should be done as like any other cirrhotic. So weight management, this is lifestyle modification, is one of the most important treatment. So weight reduction should be, if a patient is having only steatosis more than 5%, then NAS with fibrosis 7 to 10%, then NAS with cirrhosis 5 to 10%, and compensated in obese. What I mentioned is obese is because cirrhosis is associated with it's a catabolic state. So there will be wasting of the muscles, wasting of the muscle, then there will be weight loss as a part of the cirrhosis. But those patients with obese, those who are obese, then we recommend to lose some of the weight, because otherwise in a normal person, without those normal weight patient, cirrhotic patient, we do not recommend to lose weight, because that will again add up to the sarcopenia. So sarcopenia has a very bad impact on the outcome of the liver related things. So what we do is that diet is very important. In steatosis and NEDS fibrosis, we recommend calorie restriction around 500 to 1000 kilocalorie per day. They cut down the carbohydrate. Fat content should be restricted to less than 30%. No snacks, no alcohol, no smoking. Avoid fructose, reduce sugar, sweetener, beverage. Then we prefer this Mediterranean diet or intermittent fasting. Although there is the how much calorie loss is more important, what type of the food is taken. But certain, say, Mediterranean diet and intermittent fasting, they have also shown the improvement in the weight loss, but it is more important how much energy we lose rather than the what we take. Then in case of the NASH cirrhosis, the calorie intake should be, deficit should be slightly lower. As I already mentioned, we should not allow the weight loss in the patient which is not obese in the cirrhotic patient because of the fear of the onset of the sarcopenia. Then bedtime snacks should be advised for every cirrhotic patient. Otherwise, there will be this glucose uses, the muscle breakdown from the glucose uses from the peripheral part of the body. So we advise for the bedtime snack, small frequent meals, avoid alcohol, protein intake should be 1.2 to 1.5. Exercise is very important. We have this both aerobic and resistance exercise. Around 30 to 45 minutes aerobic exercise 5 days per week, or resistance exercise 20 to 30 minutes 2 to 3 times per week. Then bariatric surgery has been recommended for 35 to 40 kg meter square with a high body BMI. Then medications, we have weight reducing medications like phentermine, orlistat that can be used only in steatosis patient. Then once patient goes into the NASH and the fibrosis stage, that there is a poor evidence for those patients to use this GLP-1, all these weight reducing medications. But GLP-1 has been shown to has some role in the weight reduction.
Dr. Bobby, I'm sorry, we have crossed 17 minutes. How many more slides do you have?
Only 2 or 3.
Okay, great.
So this is the slide study that has shown the role of the bariatric surgery and this weight loss. Then diabetes, we have as management of the diabetes should be done. We prefer use of the insulin in the cirrhotic patient. So this slide, this is about the SGLT2 inhibitors and the GLP-1 agonist receptor. They have shown improvement in the NASH scoring, although there was failure to show this fibrosis score, but still they have role in the treatment of the NASH diabetes. So these are the slides that shows the role of this SGLT2 and this GLP-1. Then we have this muscle, this NASH related therapy. The government of India, this NSL has recommended vitamin E, pioglitazone, seroglitazone. So in case of the cirrhosis, we do not have any, although there are certain single center studies that have shown metformin, vitamin E, they have shown to improve the outcome, they have shown to delay the onset of the this decompensation, they have shown to delay the onset of the ICC, but they have not been still recommended for the use in the NASH cirrhosis. Now this studies also come from the Kolkata single center. They have shown the seroglitazole to have some improvement in the liver stiffness, but till now the guideline says that if the once patient has NASH cirrhosis, there is no any NASH directed therapy should be given. So only the screening for the portal hypertension, variceal bleeding, and the ICC should be done. So summary-wise, diabetes, MASH, they have bidirectional synergistic reaction. Despite the prevalence of 70% MASH, it is underdiagnosed in patients with type 2 diabetes. Risk stratification is very important. Lifestyle modification is one of the most important treatment. Pharmacotherapy has to be individualized. No drug recommendation for MASH cirrhosis. So thank you for your kind patience.
A lucid and a very beautiful presentation. How you mentioned about MELD, MED-ALD.
MED-ALD is the...
How do you approach this group of patients?
Actually, till now there is no any guideline for the treatment of the MED-ALD, but whatever we scoring with use FIB4, that can be applied in this group. But treatment-wise, we do not have till now. There is no any recommendation. How at the maximum, practically what we do is that ask the patient to stop the alcohol for around for few days, few months. Then we can think of the reducing the other cardiometabolic risk factors. But those drugs which are used in this pure muscle, they usually do not work in this setup of this MED-ALD.
What is the role of vitamin E in this group of patients who are diabetic?
Who are
Diabetic with non-alcoholic fatty liver disease.
diabetic?
Vitamin E.
Actually, the PIVENS trial was done in non-diabetic patient, but in the last slide, the second last slide that I saw in cirrhotic patient, actually vitamin, they took some of the majority of the patients were diabetic patients. There was a retrospective study, vitamin E. So there was also working in those patients, cirrhotic patient with diabetic patients. So contrary to the PIVENS trial, there was in PIVENS trials there was no any diabetic patient, but in this cirrhotic patient, they took diabetic patient also, as well as the vitamin treatment was given. So it does work. Nowadays, I see many of the from these higher institutes, they usually provide this vitamin E those patients with diabetes also.
Now the house is open for discussion.
Regarding the dietary changes, frequent snacking will have hyperinsulinemia, even causing insulin resistance. So nowadays, some researchers don't advise this snacking. We should limit this intake of food, what they say intermittent fasting. And take food, take longer time for fasting, so that we can adjust the level of the insulin in the blood. So you are advising frequent snacking here. But regarding the control of insulin, I think...
no, sir. Frequent snack is advised only for those cirrhotic patients.
Cirrhotic patients.
If the patient is cirrhotic, we need to supply enough energy because the liver is already compromised. There is no chance for the glucose storage. In case of these healthy people with if fast for 48 hours, then we have enough energy stored in the liver. But in case of cirrhotic, it does last only few hours. So we need to supply frequent energy. So this is only for those patients with cirrhotic.
Cirrhotic patients.
Yes.
Thank you. Open for discussion.
Dr. Bobby, one question. Nice presentation, but one question. What are the pros and cons of using metformin in a patient with muscle already who develop cirrhosis? About the use of metformin, the usefulness and the harmful.
This study, that one study, there was certain, but the study I quoted was one of the largest study and the retrospective study. So what they have found in there, that the reduction in the liver-related decompensation was delayed, as well as the onset of the hepatocellular carcinoma was also delayed in those patients. So these were the benefits they have found, but actually they have not found about why they have found these things, that they have come with this hypothesis that this metformin usually decreases this inflammation. They also have the immunomodulatory actions. Because of that, they have said that this liver-related decompensation and liver-related ICC is reduced. But they have not shown any other disadvantage regarding this metformin. The only thing is that metformin is not given in a cirrhotic with decompensated liver. The CTP cell B or cell C, we do not prefer this metformin.
Till F2 fibrosis. After that, it is not recommended.
Whatever study they have done is only in the compensated stage only. Once the patient is got into then it's not good.
Okay, thank you.
Thank you, Dr. Bobby, for the nice presentation. And I think this is something I think all of us are going through and will be going through. So it is a very important topic to begin the show. And next, I'd like to thank you again for presenting this. And the next speaker is our respected ma'am, Professor Rajkumari Banasri Devi. May I call ma'am on the stage, please? Madam is MD Pathology from RIMS, and then she did her DM Hematopathology from the prestigious Postgraduate Institute Chandigarh, and currently she is working as a HOD and professor of the Department of Pathology, JNIMS. She has been very academically active, presenting various forums, including national, international. She has been author of many of the recent articles. She has published many original articles, both nationally, internationally. And Madam has been so actively involved in all the scientific academic meetings of every society, including this one also. So ma'am, and she is the family of the organizing secretary, Dr. Achauwa Singh sir. So the ma'am time, the stage is all yours, but I will just request one more. We will still stick to 15 minutes so that we will have enough time for discussion. Thank you, ma'am. And I think the topic ma'am is going to talk is very important. Of course, madam will be diagnosing only, and once ma'am diagnoses, then it will help people like us again. But the thing is, ultimately, all of these patients are always there. So, ma'am, the stage is all yours, ma'am.
Thank you, the organizer, and especially Dr. Anil for introducing me in such a way, in spite of not able to provide my CV because I was busy with Amamicon, and then even my slides I prepared till now. And I forgot to send the CV, but thank you so much, Dr. Anil, for your beautiful, a little exaggerated, I should say, introduction. Thank you so much. Today I will be talking on the topic that is hematological derangement in diabetes mellitus. And through this talk, I will take you through these different sections. That is a brief introduction, followed by changes in red cells and indices, WBC, platelet, followed by a little on coagulation and the fibrinolytic system. So, as we all know, this particular disease, diabetes, is a group of metabolic disorders. And it is characterized by chronic hyperglycemia. And chronic hyperglycemia is the culprit, I should say, that is related with all the hematological derangement that I am going to tell in the next few slides. And it is also associated with abnormalities in the metabolism of carbohydrate, lipid, and protein. And it has got something to do with my cells, that is my RBC, WBCs, and platelet, and so on. So let us come to this first one, the RBCs, which are very important for us. And as we all know, the anemia is very common in diabetes mellitus, and it is usually microcytic hypochromic type. And here the indices are also important. So also, I'm going to talk a little on the erythrocyte deformability and aggregation. The changes in RBC and its indices. As we all know, as I've already said, anemia is very common. It is usually a macrocytic type. And there's a beautiful study where they have suggested that for each kidney disease, hemoglobin reduction by 1 gram per deciliter is correlated. I think our nephrologist is here, so he'll comment on that. So that is the study that has given, and mean corpuscular volume, it is reduced. And unlike in iron deficiency anemia, whenever mean corpuscular volume is reduced, we get reduction in the MCH and MCHC, but in diabetes, MCHC is increased. And changes in other indices like hematocrit. Again, there are many studies which has correlated hematocrit, increased hematocrit with hyperinsulinemia, insulin resistance, and hematocrit is a measured discriminant of blood viscosity. Now coming to the next important one, that is erythrocyte deformability. Why we are so much concerned with this erythrocyte deformable? Because the lumen of the capillaries, where the tissue will be receiving the nutrient and the whatever is carried by the blood, the size is only 5 to 9, and most of the capillaries the size ranges to 6 to 7 micrometer. As we all know, the size of the RBC is larger, that is 8 micrometer. How will it go through it? Because it has the capacity to convert into an elliptical form, so that it can pass through this micro system, microcirculation. And there are certain determinant of RBC deformability, which include RBC shape of the RBC. As you all know, my PGTs know, if there is a spherocytosis, we keep on saying that the lifespan of the RBC is reduced. Why? Because it cannot go through it. Once it is clogging is there, then your good macrophages will come and clear it. And then mechanical properties of the RBCs, membrane and its cytoskeleton do also play a role. And so also the intracellular viscosity. So if the intracellular viscosity is maintained, then RBC can easily maintain that deformability. It can easily convert back to, again, this sepet or elliptocytes. Elliptical set, not exactly elliptocytes. Now let us see what are the effects of hyperglycemia on erythrocyte deformability. So hyperglycemia, or I'll put it in this simple word, high HbA1c. I think I'll be more comfortable with it. So it adversely affects hemoglobin, because hemoglobin will become glycated. And as you all know, my students know, there are different hemoglobin, glycated hemoglobin, and in the context of diabetes, we are concerned with hemoglobin A1c. Again, hemoglobin is reduced, and membrane fluidity of the RBC is reduced. Membrane protein of the RBCs are also reduced. So overall, there will be reduced erythrocyte deformability in case of diabetes. So it will lead to the impaired perfusion at the tissue level and decrease RBC survival. So in diabetes mellitus, there is the deformability is reduced, leading to the ill effects of which I have already told. Not only this, we can sometimes come across erythrocyte aggregation. Again, what are the factors which can determine the erythrocyte aggregation? These are these aggregating forces. I hope it is seen or not. Cursor is not seen anyway. It is a balance of the disaggregating and aggregating forces. Disaggregating forces are the fluid shear forces, electrostatic repulsion between RBC and RBC, and then elastic energy of the RBC membrane. Aggregating forces are many, and the important one is adsorbed macromolecule. In this context, these are the glycated product. So in diabetes, the favor is towards the aggregating forces. The aggregating forces are overpowering the disaggregating forces. So I have a beautiful case that came yesterday, so I thought that it will be good to share it. It's a 72-year-old, and the patient was referred from one of the nephrologists, and the patient is a known case of diabetes mellitus, uncontrolled diabetes mellitus, and he was undergoing regular dialysis. As we can see here, hemoglobin is reduced, there is bicytopenia, and the neutrophil is increased, and platelet was reduced. And what is important in this is that the MPB is also increased. MPB, I'm going to talk on MPB in the next few slides. MPB is the mean platelet volume. It is increased and it is associated with prognosis of the bad prognosis of the diabetes. That I'm going to elaborate in the next slide, which I was expecting to find a MCB of less than 80. But in this particular case, the MCB was so high. And I was thinking why it is diabetes, and I expect MCB of less than 80. And here MCB was very high. And a look at the peripheral smear will explain everything. There were a lot of clumping. And if we see clumping, we don't like to see clumping. I keep on telling my students, if you see clumping, first remove all the pre-analytical variables, make sure that the sample is collected in the correct vial, and then after that you go and check the reticulocyte count to see whether there is any sub pointer towards hemolysis. But here in our case, it was, is it time? 9, it's written 10 here, 10 minutes here.
It's not from us.
Okay, I was worried, but I'm trying to hasten it. Anyway, so here again RPI was very low, and Darikund test was done, it was negative. So it was not the clumping that you see here, it's not due to autoimmune hemolysis. What are the possibilities again here? Is it due to diabetes, uncontrolled diabetes per se? Or is it due to the frequent dialysis this patient has undergone? The case came yesterday, and we have to dig out a lot more. Now coming back to the RBC aggregation, as we all know, if RBCs are aggregated, again it will increase the risk of atherosclerotic plaque. Chairperson, please kindly remind me the time also. Okay, maybe 2 minutes before that. Okay, I think it's only 11 minutes anyway. So RBC, especially at the bifurcation of the coronary and the carotid, there's the whole blood recirculate and becomes stagnant. And at this area, the RBC in diabetes, they become adhesive. And if the RBC becomes, yes? Okay, if the RBC becomes adhesive, then it will increase the risk of atherosclerotic plaque formation. And it is aggravated, again, this risk of atherosclerotic plaque formation, it's aggravated by endothelial dysfunction. Again, endothelial dysfunction is seen in diabetes. Why? Because there is hyperglycemia. I have repeatedly told hyperglycemia all the time. It is the culprit. Because of hyperglycemia, there is increased production of your activation of our arachidonic acid metabolism, leading to the increased oxidative stress, and ultimately leading to the endothelial dysfunction. RBC aggregation, lack of reduced RBC deformability, along with endothelial dysfunction, these are the main factors which are aggravating or participating in the production of the atherosclerosis, which are very common in diabetes. Now coming to the, this is all about RBCs. Now coming back to the WBCs. The WBCs are also equally affected. Here I'm going to talk on total leukocyte count, NLR, that is neutrophil lymphocyte ratio, PLR, platelet lymphocyte ratio, and absolute lymphocyte count. What is the pathogenesis? Okay. Yeah. So here the advanced glycosylation end product, that is AGE. It is because of this the WBCs are activated. Once the WBCs are activated, they don't sit idle. They will produce all the cytokines and transcription factor and superoxides. Again, there will be increase in the oxidative stress. Again, ultimately it will participate in the pathogenesis of diabetic microvascular and macrovascular complication. Now, this is the etiopathogenesis of the effect, how the WBC take part in contribute towards the etiopathogenesis of microvascular as well as macrovascular complication. I'll be coming back to this NLR, PLR afterwards, because I'll be discussing these two together. So let me briefly mention about platelets. Platelets, again, effect of uncontrolled diabetes on platelet. There's an increased baseline activation of platelet, including stimuli-induced and aggregation response. Platelet becomes hyperactive. That means there'll be increased risk of atherosclerosis. And the platelet is very important, even though these are the smallest cell that is seen in the circulation, but it has got more to it than its size. Again, MPV is the surrogate marker of platelet activation, as everyone knows. And activated platelets are strongly related to inflammation. MPV increases in diabetes and it is characterized by subclinical inflammation. MPV was found to be higher in diabetes mellitus and linked with vascular disease. I'm going to elaborate with certain beautiful studies that has been conducted. This is one study where the author have taken 300 cases of type 2 diabetes mellitus, including controls, where what they have found is that platelet count was significantly decreased, p-value less than 0.005. And so also the MPV and the, MPV and the PDW, they are significantly increased. And they even suggested that this can be taken as a surrogate marker of those who are prone to develop complication. However, PLCR, which we all love to see, it doesn't have any role, or it's not significantly changed in diabetes mellitus. And role of MPV, again, another beautiful study. Here, the MPV values are higher in uncontrolled as well as uncontrolled when compared to the controlled diabetes mellitus. And the authors have suggested MPV could indicate and play a more important role in the detection of vascular complication of diabetes. Kindly note this, vascular complication of diabetes. And in all our CBC report generated from JNIMS or anywhere, everywhere, we have MPV, PLCR, then PDW. So in diabetes patient, I think we can predict who, out of those person who are having high MPV and PDW, they can have more complication compared to the uncontrolled ones. Regarding to NLR, that is neutrophil to lymphocyte ratio, and PLR, that is platelet to lymphocyte ratio, and absolute lymphocyte count. There is a study here, the WBC count, then absolute lymphocyte count, MPV and NLR and PLR were significantly associated with impaired glucose regulation. Again, it's a huge series of patients where in this particular study 1,790 patients were included. Here again they found positive correlation between HbA1c and ACE, HbA1c and white blood cell count, hematocrit, MCB, RDW, and NLR. And it was found to be significant. And quoting this, we have searched our literature and we found
how many more slides do we have?
Yeah, I'll finish it. I'm going to finish. Two more, I think. Yeah. Here, the MPV, the HbA1c was slightly increased, and we found this NLR ratio was within normal range, and the MCHC was increased. And it is a case of non-diabetic. Actually, this particular slide I just wanted to show because the HbA1c is increased. When the HbA1c is so much increased, it's not corresponding with the the clinical finding kindly suggest for a better analysis to check whether there is any hemoglobinopathies. Here, in this case, we had correlated, we had a coexistent hemoglobinopathy. So effect in coagulation and antifibrinolytic pathway, there are many studies which have predicted the prothrombotic state that is seen in diabetes mellitus. And to summarize, hyperglycemia has a range of effect on RBC indices, then excessive oxygen product, and total leukocyte count, NLR, then these are significantly associated. And these are my references, and thank you. Thank you so much for your patient hearing, and thank you, Dr. Anil, for providing me another extra 3 minutes without me knowing it. Thank you so much.
Thank you, ma'am. It was a very nice, lucid presentation. Now the house is open for discussion. Any comments or any query, please feel free.
Thank you, madam, for your excellent presentation. Just a query came to my mind. How do you often see a diabetic patient who is on SGLT2 inhibitor, and sometimes do you often see that the hemoglobin is quite a bit on the higher side? Like, has it ever come to your notice, like especially in diabetics who are having a frequently high hemoglobin, like erythrocytosis level, like 16, 17?
That I'm not aware.
Okay.
But which drug you mentioned? Because I'm not familiar with your...
Anil would be the better person. Like, because now off late we're using a lot of SGLT2 inhibitors.
Okay.
And for some reason, my belief is that we are seeing more and more of diabetic patients with a much higher hemoglobin than it used to be.
Okay, thank you so much. I'll look into that. I'll be more aware the next, when any diabetic patient comes, I'll look into that. Thank you so much.
I personally also have seen that in Manipur as such, majority of our patients are having higher hemoglobin. Whenever we walk up for polycythemia, what we found is that it is never classical, because ma'am will accept also. So like erythropoietin level is not very low, high also, JAK2 is normal. Then sometimes we do marrow, we expect some hyper cellularity where the bone marrow will be hypocellular. So what I felt is that the Manipur SS, they say that it's not just a hill or valley, it's just a part of the hill. So the sea level of, from the sea level, Manipur is saying around 790 meter the valley. So probably I'm thinking of late, we have not done a study yet, so is there anything to do with this? I don't know.
Yes.
And regarding the SGL2, Dr. Rajesh has said, I have not actually come across patients using SGPL2 and diabetes of late, because I am not following many of them, because I don't treat diabetes also. So if I come across, I'll also try to find out.
Yeah, regarding this erythrocytosis, many a times, as Dr. Anil has said, as I don't know what that's relevant with that doctor has asked, the JAK2, and then we will check both 14 as well as exon 12. Many a times it's negative. And then one of our consultants, son, also having the same issue. And we have, one of my junior have conducted a study where they have found certain mutation in other genes other than JAK2, like these certain other genes like associated with the destruction of, yes, ma'am.
Good afternoon. I just wanted to give a comment on increased hemoconcentrations in patients with SGLT2 inhibitors. And as we know that SGLT2 inhibitors, in many patients, if we are not
Madam,
really careful.
SGLT2 one drug, because I'm not aware.
No, it's okay. And so, if we are not very much, say, concerned about, then, the patient may have dehydration, that is one factor, and so there may be hemoconcentration. And not only that, the erythropoietin is usually increased with these drugs, and so that also may give rise to increased hemoglobin and hematocrit. Okay.
Okay, ma'am.
Sir.
I'm just invited, I'm interested to speak at this level. It is my subject. SGLT2, as the speaker, my own wife, doesn't know what is SGLT2. SGLT2 is sodium glucose.
What is
it? It is one of the medicines used for treatment of diabetes, and this is one drug which can cause urinary excretion of glucose through urine. We have many medicines targeting many organs nowadays, not only the pancreas, not only the liver. So we are targeting the liver, we are targeting the central nervous system and everything. So one such is one targeting kidney. Rajesh department using his department as the cause for control of diabetes because it excretes. So as all of us know, one molecule of glucose carries 2 molecules of water. That is what. So there is, as Riley said, Ma'am Taruni, that it may be a cause of hemoconcentration. Riley said. So we have come across as hematologists, and we are very fortunate to have a hematologist, then nephrologist, then hematopathologist, radiologist, all. So one such example I can give now is referred by Dr. Anil, one prominent personality, non-diabetic. Urine is full of glucose, 4+. So glycosuria, perplexed, what to do? So I said, what are the medicines you are taking? He has been prescribed SGLT2, one of those. He is non-diabetic, many times done frequent check of sugars within normal limits, and sugar is there 4+ all the time. So I think Dr. Anil must be remembering that also. He is a personality, I won't quote the name, but he was convinced that he was given by one of the cardiologists or maybe nephrologists that the SGLT2 is one of the medicines used for treatment of diabetes as well as kidney protection, heart protection, every sort. So cardiologists are very fond of it and nephrologists are also very fond of it. So that's what I convinced. So SGLT2 is a kind of molecule which excretes sugar through kidney. So that's why Ma'am Taruni said it may be a case of hemoconcentration. Israeli said. I think most of the cases, this is what we have been trying for. In the treatment of diabetes, we plan for weight reduction. So this is one of the medicines which can reduce the weight reduction as well, in spite of only doing good things for glucose control. So I have found many, yes, I do agree with Anil, Dr. Banasri and Dr. Rajesh that we are having some sugar of hemoglobin of 17, 18. We are worried. Because if I don't do, then I will be blamed by Anil that you have not done anything. So we do something further checked up, and it is found that your erythropoietin is normal, PEG cell volume is normal, and how do I go about? So then we often refer to hematologists for further workup. So they send back to us that they are normal. I don't know, this is the concern of today's diabetes and hematologists, hematopathologists, neurologists, nephrologists. Okay, the forum is for you, and this is the discussion, very nice, and Anil will moderate the things further. Thank you so much.
I think with this we'll come to the end of today's session, and even me, since I don't use SCPL2, I was not very much aware of this, and it's truly wonderful to be back. Actually, yesterday when I visited all the stalls, then I was trying to remember some of the drugs also. So ma'am, thank you, and we'll go ahead with the next stall. I want to kindly introduce Dr. Rajesh.
Next,
If I may be allowed, can I just introduce a little more? Yes. He is, I think, the first ever nephrologist from, I think, Manipur, who is doing renal transplant in a government hospital. He did his DM from Kolkata, and then he joined JNIMS as an assistant professor in the year 2012, if I'm not wrong. And then since then, he has gone for further training in Canada for another 3 years. Then he has been with JNIMS. He is one of the most important personality for JNIMS, and he has been, I think, if I'm not wrong, performed more than 32 training. What was that?
No, we've done 66.
Oh, I'm so sorry. So I think I should introduce a little more. So I took this opportunity. He has done more than 60 transplant. So the stage is all yours, and if you may allow us, please. Do it in 15 minutes, we'll just give you a warning so that you can just try to wind up. Thank you.
Thank you for the kind words. Disclaimer, my slides usually are very colorless, and I will not be surprised if I see a few eyes shut during the presentation. Okay, with that, I move on to my slides. Everything will be more like a clinical case. I don't like to go too much into theory. I think it just dilutes the purpose of the presentation. What I usually prefer is in a presentation that the audience learns something from it which will affect or change the way of managing the patient. So, let me begin with this question, that why does the kidney get affected in diabetes? And you can say, okay, if you have diabetes, if you have had it for a long time, then there is increased pressure inside the kidney, and we call it as intraglomerular hypertension. So any person, a diabetic, if they develop this, they are at a risk to develop a clinical diabetic disease in the future. So this is important because, let's say for example, if you have a patient who has kidney stones, and the urologist removes the kidney, I'm very concerned. Because half of the nephrons are gone, the remaining half are going to undergo hypertrophy, and that puts the patient at a risk for clinical diabetic disease. And that's for the same reason why we don't take a diabetic patient as a kidney donor, because eventually down the line, you know that they are going to develop kidney disease. Okay? So, I think it's also important for, especially for parents to know the birth weight of the child, because if the child is low birth weight, when they become diabetic, they are at an increased risk to develop diabetic disease. So I think the parents should keep that in mind as well. So anyway, the bottom line is one very important factor is the intraglomerular hypertension. And why does that happen? I think a lot of it has to do with the renin-angiotensin system. So in diabetic patient, the renin-angiotensin system is activated, and so when we start thinking about the treatment, when we start thinking about the novel treatment for diabetic disease, you want to address each and every one of those abnormalities that you see in a patient with diabetic disease. And one such abnormality is the intraglomerular hypertension. So what options do we have? So we have been relying on RAS blockade, and this is one of the main, what I should say, a treatment, one of the cornerstone for the treatment of diabetic disease. And we have been using it for many years, I think more than 2 decades now. But it's not a perfect medication. So, in fact, so we need to find another agent that can reduce the intraglomerular hypertension a little bit, in a more efficient way. And one such medication is your SGLT2 inhibitors. Okay. So, what does the ARB do? SARB do? They dilate the efferent arterioles. So they act at the level of efferent arteriole, and by doing that, by dilating that, the capillary perfusion pressure is reduced. So that's why some patients, when you start on ACE-ARB, you find that, okay, in 1 week time, the creatinine goes slightly a little bit on the higher side, and that's because the glomerular perfusion is affected a bit. Okay. Now, SGLT2 inhibitor, on the other hand, they cause constriction of the afferent arteriole, okay, and that's because of the tubular glomerular feedback mechanism that happens here. So when you put these two medications, so the efferent arteriole is getting dilated and the afferent arteriole is getting constricted, so that will lead to something, a situation where there's poor blood supply in the capillary, and that's why the GFR drops a bit when you use a combination of these two medications. So I think the combination is doing a good job, because some 11 years back, when we were studying, the rate of fall of GFR in the diabetic disease was around 10 ml per minute. That means every year, a person with diabetic kidney disease, they lose 10 ml. So let's say if someone has a 50 ml GFR, so that would be somewhere like a creatinine of 1.5. In 5 years' time, so it was 40, 30, 20, 10, so they go into end-stage kidney disease. So that was how the rate of progression was. But now you fast forward some another 13, 14 years, and we find that the rate of progression has slowed down significantly, and I think most of the trials now report maybe 1.8 to maybe 4 to 5 ml. So that means not only the medication, but something has changed, maybe better sugar control, more awareness. I think maybe we are leading in the right track of managing a patient with diabetes and diabetic disease. So the first component of a kidney getting involved is the raised intraglomerular hypertension, and we have two medications in that context. The second component is inflammation and fibrosis. I don't think discussing the pathology will help now at this point, because it's really, really huge and beyond the scope of this presentation. But nevertheless, what is important is aldosterone and the RAC1, the combination of these two play a very significant role in promoting fibrosis and inflammations in patients with diabetes. So how do we use this information? So for a long time, people were using the steroidal mineralocorticoid receptor antagonist, and so I remember till 2010, I think we were using a lot actually for IgA nephropathy, and the on-target trial was published around that time, and it said you should not use it. So you should avoid using a RAS blockade plus an MRA, because it increases the risk of hyperkalemia and AKI. And the enthusiasm for using spironolactone epinephrine was curbed after that study. But with the publication of the feasibility studies of late in the last 2 or 3 years, I think there has been a resurgence, and I see a lot of prescriptions, a lot of physicians, cardiologists, nephrologists, even endocrinologists writing a combination of SARB plus a non-steroidal mineralocorticoid receptor antagonist. So nowadays, we more frequently use a non-steroidal MRA, finerenone, rather than the conventional potassium-sparing diuretics. And what advantage of using a non-steroidal is the risk of hyperkalemia is a bit lower as compared to your spironolactone of your eplerenone. Okay, so every diabetic patient, and I always make it a point, and I would say nearly 90-95% of all the patients that I see, diabetic patients, I think they are on eplerenone. So usually these anti-inflammatory will serve as the third pillar for treating a patient with diabetic kidney disease. Okay. Another drug, not very known by clinician, but I usually I write it quite frequently, and that is pentoxifylline. And we have a few trials, the Triton trial, but I will use it for diabetic kidney disease as well. So the second important component of diabetic kidney disease is inflammation and fibrosis, and in that context we have two medications. One is your finerenone, and the other is pentoxifylline. Okay. So now we come to the third aspect, and that is the metabolic dysregulation. So you have obesity, then you have inflammatory state. Because of obesity, the visceral fats promotes the inflammatory state. You have advanced glycation end product and the receptor for advanced glycation end product interaction. Anyway, a lot of things are going there, and one solution to that would be obesity reduction, but also you could try the GLP-1 agonist. You can try the semaglutide and or the liraglutide. So I think this slide just sums up the basic treatment of a diabetic disease. They should be put on ACE-ARB, they should be put on SGLT2 inhibitor, they should be put on a non-steroidal MRA, and they should be put on GLP-1 agonist. The question is, we also have to see how much they cost, because these medications are not that cheap as well. Okay, so these background, I'll move on to the second slide. SGLT2 inhibitor, why do we want to give it? So it improves cardiovascular outcome. A lot of cardiovascular trials are there. I will not go deep into that, but it's good for the heart. That's sufficient. What about the kidney? It says primarily most of the early trials were on cardiovascular trial, but with the credence trial, I think the subsequent 3 large randomized trials were more of a kidney-oriented trial. So you have the credence, DAPA, and the EMPHAL kidney all showing a delay in the progression of kidney disease. So we will use SGLT2 inhibitor to improve the cardiovascular outcome and also to improve the kidney outcome. So with that background, we'll discuss this case. So 48-year-old man, diabetic for 10 years, ACR is around 1.7 gram, has got some retinopathy as well. GFR is 45, HbA1c is 7, on insulin, metformin, olmesartan, statin. A diagnosis of clinical diabetic nephropathy is made. And now, the clinician decides to add dapagliflozin 10 mg and ask for review after 4 weeks. So the GFR was 45, and after 4 weeks, the patient comes creatinine 1.6, and GFR is now 40 mils. What has happened? And the patient is a bit upset that, okay, my kidney function worsened a bit. So I think this is just a repetition of what I said earlier, that it's the combination of the dilatation of the efferent arteriole and the constriction of the afferent arteriole that's leading to a sort of a hemodynamic mediated API, which is very commonly seen in patients when you put them on SGLT2 inhibitor plus ACE or ARB. Okay. So in clinical trials, so you have the list of the clinical trials, and we see the fall in the GFR, the initial dip in the GFR, when you put them on a new start of SGLT2 inhibitor, is usually around 3 to 6 ml. Okay. So if you started at the GFR of say 45, then you're not surprised if it comes down to 40 when you started at the end of 4 weeks. Okay. And the patient says, will it come back to the baseline? And many times, I think we say yes, and the answer is no. It doesn't come back to the baseline. If you stop the medication, it will, but if you allow it to continue, it will not. So you look into this slide there. The blue line shows the fall in the GFR, and you can see that there is a sudden fall almost to the extent of 5 ml. Yeah, this is from the previous trial. So there was a fall in the 5 ml at the end of 1 month. There was a slight improvement, maybe improvement of 1 ml, and after that it deteriorated. Okay. So at the best, what we should say is there will be a partial recovery, but it's not going to touch the baseline GFR at what it was. Okay. So if there's only a partial recovery, then should you continue or not? So let us look at the overall graph then. So the blue line, we'll start with the placebo group. This is from the credence trial. If you look at the yellow line, okay, the baseline GFR was something around 48 mils. And as we follow them up, the GFR fell by roughly, I think, 4 to 5 ml every year in the placebo group. Okay. So the starting off was, let's say, a GFR 48, that would be around 50. And the fall of GFR is around 4 to 5. So in 10 years, the patient reached dialysis stage. Okay. But if you look at the canagliflozin group, even though there was an initial dip, the rate of fall was around 1.85 ml every year. So the rate of progression to the dialysis stage was 25 years. So the patient got saved of 15 years of renal survival. So based on this, and there was a lot of enthusiasm when this was published, that if you put someone on ARB plus SGLT2 inhibitor, okay, so you're literally going to save 15 years of life of the patient from going into dialysis. Okay. That is one way of interpreting it. So one has to have the wisdom of looking out for longer views rather than a short temporary relief. Yeah, but this is a theoretical extrapolation. The real life scenario is a bit different. It's just like the stock market. You read the stock properly, you read the fundamental analysis, do the technical analysis, and you say, this is a great stock, I'm going to invest. And then something unexpected happens. The market crash, you have the war coming up, India, Bangladesh crashes, COVID happens, stock market crashes. Same thing happens in most of the diabetic diseases as well. Because many of these patients, sometimes they develop infections, sometimes dehydration, and sometimes what happens is we very often encounter a much rapid progression of loss of renal function as well. Okay. So this is a very recently seen patient, 41-year-old female, diabetic for 8 years, and creatinine was 2.7 milligram in March, GFR was 22, and patient is on good medications. A repeat test done 2 months later, the kidney function had worsened. The GFR had gone up to 11.9, and the clinician had removed ARB, and the rest were allowed to continue. And I don't have much information what happened, but the patient came to us in the month of October, and the creatinine was 6.7, the GFR was 7.4. So that means the patient lost 15 ml of GFR in a short span of 6 months. So what has happened to this patient? It was supposed to save 15 years of renal survival, but something went wrong. So the credence trial, I think the mean GFR was around 50. Okay. But this patient, when you started it, the GFR was 20 ml. The data from the credence trial will probably not apply to these patients. So you will not say that I'm going to save 15 years of the kidney life for this particular patient, because the rate of progression, once the GFR goes below 25, it may be different. So what evidence do you have? So you have the DAPA-CKD trial, which included 25 to 75 males patient, and you have the IMPHAL kidney, which looked into patients with GFR of 20 to 45. So both of these trials include a more severe renal failure involvement. And I'm quite surprised that the results are so good. The rate of fall of GFR was 1 ml per year in MRPD. That's a very, very good result. I'm quite surprised though, because what we see in our clinical practice are a bit different. Maybe we are doing something wrong. Okay, so anyway, so this patient technically qualified to be in the IMPHAL trial. And she received the appropriate medication at least, as she should have done. But she lost 15 ml GFR in 6 months, which is a bit unusual if you compare it with the trials. So, when someone comes with an AKI and SEL2 inhibitor, we should not only think about the hemodynamic mediated AKI, we should also think that there are other causes of AKI that can happen in a patient who is taking a SEL2 inhibitor. Okay? So, we have cases of osmotic nephrosis and AKI, like patient who was doing well, started on SEL2 inhibitor, rapid worsening of renal function, going to the dialysis stage. We do a biopsy, the tubules will show a lot of osmotic vacuums. Okay? So this was published, another publication pretty much showing the same findings.
But just maybe around we have crossed.
15 minutes, okay.
Yeah, we have crossed another 3 minutes also. Let's see if you can wind up.
Okay. I think I can stop it here and then we can take it.
So
very good presentation, Rajesh. Congratulations.
We love to.
And as we all know, diabetes, kidney disease is very much is a sort of disease which is fast developing in the management part. Even, I mean, for prevention of this fibrosis, then cellular hyperplasia, all those things, every caveat we can have for prevention of this progression of disease. And one more thing, just for this information of the audience, up to what GFR you will allow to use this SGLT2 inhibitors and this AC inhibitors or this.
So clinical trials, they have included till a GFR of 20. But it becomes a bit tricky at that point because sometimes there's just a rapid worsening of renal function that's something that seen at that point. So I'm very, very careful, very, very cautious when we put someone on a new start of SGLT2 inhibitor plus SARB in a patient with GFR around 20, 21 ml. I think that's a bit of caution. But clinical trials say you can do it. And just the one point I wanted to highlight, because I was so upset with, and our local experience is very different from what is typical in the clinical trial. And I feel at some point somebody is going to stand up and say, maybe it's not doing that great of a beneficial effect as it should be. Okay. I really wanted to present our data, but I didn't have time. I was given this topic only 3 days prior, so I didn't have time. But what I wanted to show is that the initial dip in the GFR in our population is much, much higher than in clinical trial. And I was trying to figure out why that is happening. And then I looked at the weight. Our average weight at which we start this medication is 48 to 53, 54 kilo. Now you look at the weight of the patient in those trials, like for example the DAPA-70 trial, it was around 79 kilo. So that means the total body water is quite different. There is a 15 liters difference in the group. I think that's also one contributing factor. So for that same reason, so what we did was we started this trial where we give SGLT2 inhibitor on an alternate day basis rather than give on a daily basis. And our logic is by giving some off day, whether we can still retain the beneficial effect and reduce the side effects. So we have 2 ongoing trials. One is the daily versus alternate day, and one is daily versus alternate day versus twice a week schedule of SGLT2 inhibitors.
Regarding this one, AC and this.
Yeah, I think there was a hypothesis that you mean the GFR at least we can get
up to what GFR you allow to continue.
I usually give it in CKD stage for around GFR around 1920. So there is a population study I'm doing a Swedish population where they allowed it to continue till GFR of around 20. And the concern becomes the risk of hyperkalemia at that point because the potassium excretion is affected. So I give it till around 20. But once it goes below 20, then you get a bit cautious about hyperkalemia.
Then have you come across about SGLT1 inhibitors on the...
I think canagliflozin has some amount of SGLT2 plus SGLT1. So I think endocrinologists can correct me if I don't know. Sotagliflozin, yes. I think it acts predominantly on SGLT1. But what we also have to understand is SGLT1 is mostly present in the intestine, and I think some part, I think, is there in a string part of the proximal genes. So I don't think, I'm not aware of any clinical trial which really have shown any benefit. I'm not aware of that.
So one may have any opinion about this?
But what I do know is that in canagliflozin, the effect of SGLT1 blockade is very, very minimal.
The effect of these SGLT1 inhibitors on kidney, any study have you come across? Not versus. Have you used SGLT1 also?
First of all, I would always say congratulations to my brother, the speaker, nephrologist, Dr. Rajesh. Sorry, apologize that I gave you a very thin period for your preparation. That is my apology. There was some miscommunication between you and me also. But nonetheless, everywhere you are there, the function is very complete. That is one I can say. Regarding the topic of academician, SGLT2 1 and versus 2, I would say. I don't know about kidney, but SGLT1 inhibitor accounts for around 10%, and 2 inhibitors accounts for 80 to 90%. So this is what people should think of. What does it mean? In one way, it may be inconspicuous. But nephrologist's perspective, I don't know, I have to learn from you all. But from endocrinology and the diabetics treatment people, I think somebody would highlight. Yeah, Brojan, I think my comment is like this. So think of 10% versus 90%. Okay, what would be the effect? And everyone on this universe and Manipur, I think in the field of kidney disease and diabetes, SGLT2 is a very important molecule used by many people, and somebody using without knowing everything, somebody using it with some knowledge, somebody versed with many knowledge. So comment is like this. So Rajesh, I think it is up to you to comment now. Okay, thank you.
I'm not even sure whether that product is available in India or not, but I think endocrinologists should know more about it than me. I've never used an SGLT1 inhibitor in my life.
Yeah. That's what. If anyone using from nephrology side, please comment. There is no molecule from my side, endocrinology side, to be used in the market. Thank you.
Yeah, I think point is very clear about this one, diabetic kidney disease treatment part, SE inhibitors, ARBs, SGLT2 inhibitors. The thing is that we have to counsel the patient feelings. Patient, we have to educate. Many patients nowadays, after going through Googles, when we start SE inhibitors, ARB or SGLT2 inhibitor, with increase of some point in the creatinine, they will change the doctor. And saying that Dr. X has given me and my kidney function has deteriorated. But just also might be facing this problem. I mean, many patients of mine might be coming to him and each patient coming to me like that only. So I keep on explaining them that this long-lasting effect is more beneficent. And so any comment from?
I think a 5 milligram initiation or a 10 milligram alternate, I think it looks to be
Yeah,
better.
we should have the results. Okay.
Just there is a fight between nephrologists and cardiologists. If any cardiologist around here, Sumitra, so there is a fight between nephrologists, not to endocrinologists. They are fighting. The introduction of SGLT2, people will say that they will say something, and there is something we have to bind ourselves. Endocrinology, nephrology, then the cardiology, because people die of cardiology, cardiometabolic disease, ultimately, and kidney disease. We are treating, and we depend on Rajesh, we depend on Rajan, and we depend on Tamarajendra. And when you scold us, then I don't have any way to escape. It is for everyone, I think. Sir Mangalam will agree with me. If I write something, Rajesh said 5 milligram, then somebody writes 10 milligram. Which one is enough? No, nothing is concrete. So,
I think we should take the weight of the patient into account.
Yeah.
If someone is 80 kilo, healthy, and I think it's okay. But I feel very thin, frail, elderly females, I think they are at a risk of a much rapid acute worsening.
Okay.
That's what we have observed also.
Okay, thank you so much. I'm just coming out just to lengthen the program. Okay, thank you. Yeah.
I have, sir, actually I'm a pediatrician, but I have something in my mind. So the people now it is a teamwork, so like tumor, both these endocrinologists, nephrologists and cardiologists can have diabetes both, my suggestion.
Thank you, Dr. Rajesh Vaipu. Now we call upon Dr. Kanjal Suras, DM Neurology, AIMS New Delhi, Professor at Department of Neurology in IMPHAL, and he will be presenting the topic treatment of diabetic peripheral neuropathy. Dr. Suras has had many national and international publications, and quite many times he was a resource person in many national forums. So over to Dr. Kanjal Suras.
Good morning. To this topic given to me is management of the diabetic peripheral neuropathy. It was probably five years back also we have same conference. I have spoken, I have been given the same topic. This time I'll be talking a bit more concentrating to the peripheral neuropathy. So coming back, I'll be talking more of a treatable neuropathy related with the diabetes. So slide set okay, no, slide set. So we have diabetic neuropathy, we have peripheral neuropathy and autonomic neuropathy. And in the usual peripheral neuropathy, I would like to more of divide this neuropathy in three groups. For management part, I'll be dividing this. This is just for presumably I have grouped this neuropathy in three groups. First group will be like usual peripheral neuropathy, what we are seeing most commonly in the So most commonly we see in the clinical practice mostly this group is So group 1 is slowly progressive, typical what we see clinically sensory motor axonal neuropathy, which is distal predominant, and clinically they are seen as globe and stocking pattern type. Type 2 or group 2, I would like to put in this group some asymmetrical neuropathy and some inflammatory diabetic neuropathy, which has been lately recognized. And these two groups, I'll be discussing more on these two groups because it may be treatable, which has been long in the this thing we have already very much discarded or not treated probably in this long run. And group 3 is entrapment neuropathy. So group 2 consists of mostly asymmetrical and immunological related diabetic neuropathy. So in this we have lumbosacral radiculoplexus neuropathy, what we call is, previously we used to call them as a diabetic amyotrophy. Another in the second in this group is CIDP kind of presentation in diabetes associated with diabetes. Then the third is multifocal neuropathy, like we see in the kind of vasculitis related, like in the SLE and all, multifocal motor neuropathy, or what we call mononeuritis multiplex kind of thing. Other focal neuropathy, like you have cranial neuropathy and truncal neuropathy in this group. One interesting presentation in this group I'll try to include in this group is acute painful neuropathy, like especially diabetic neuropathic cachexia. These are infrequent, the cause is actually not known, but the pain are very severe in this kind. Still, they are very much effective. They are good with the steroid immunomodulation. Still, one of the treatment best for this type of neuropathy also. So I include in these two groups, even though the pathophysiology is not known. And last in this group is insulin trigger neuropathy. Regarding the treatment of all this neuropathy, as we commonly see that I have put in group 1 is what distal peripheral neuropathy, even though their pathophysiology has been well described, it is related with hyperglycemia, it is related to metabolic or ischemic changes and all. Still, we don't have any drugs as a disease-modifying drugs. So we only treat this symptomatically, mostly for the pain. The treatment in first line in this is gabapentin or this pregabalin, gabapentin or duloxetine are in first line. Other drugs used are tricyclic and the SSRI, they are used in single or in combination. This I won't be talking, you all know, people are all using, I won't be talking much in this. This group 2 is important in that sense that they have immunological, some pathophysiology has been detected nowadays for diabetes. So diabetes like hyperglycemia, insulin resistant, hyperlipidemia, they can initiate or they can initiate some cell injury or cell inflammation changes. All these can cause secretion of the cytokines and chemokines, inflammatory chemokines that in turn can damage these nerves. So this has been already, this has been a lot of publication, pathophysiologically proven publication is there. So the role of low-grade inflammation in the pathogenesis of diabetes mellitus, the peripheral neuropathy is well established and the underlying cellular mechanism has been already identified. So this diabetic inflammatory neuropathy, usually they are overlapped with the usual diabetic sensorimotor neuropathy. And this can be identified clinically also, and it can be proved with the investigation like electrophysiological nerve conduction studies or laboratory tests, other like biopsy and all. They can, again, there are series that has been proven, proved these things. They are clinically suspected inflammatory neuropathy were identified by subacute onset, progressive sensory or motor neuropathy, and diabetes, in especially those who are fairly controlled blood sugar. So these are identified by your clinical this thing. Then one of the features of inflammatory diabetic neuropathy is they are usually occur in the early case of diabetes and early in the diabetes, and higher prevalence of limb weakness, and they have severe like weakness in this, not like globin stocking, slowly progressive, not that they have quite faster onset and severe involvement, and there are the electrophysiology by nerve conduction studies, more severe abnormalities we can detect. They have both demyelinating and axonal changes in the nerve conduction study as well as in the sensory nerve biopsy also you can see both these changes. Then there may be associated perivascular inflammatory infiltrate, decreased fiber density, increased demyelination, and axonal degeneration. Most important in this is very amenable to the immunotherapy. This has been published, and this there have been case series already published with this, that this inflammatory diabetic neuropathy is associated with usual sensorimotor neuropathy, and they have treated with immunoglobulin in some of the series. Then so I'll be taking in account, after having this, there are some inflammatory changes in the diabetic neuropathy, so I'll be taking one by one of this in this group. Like diabetic amyotrophy, we have two types in this diabetic amyotrophy. One is asymmetrical onset or asymmetrical presentation, one is symmetrical presentation. Symmetrical presentation is slightly rare, asymmetrical presentation is more this thing. Then asymmetrical presentation, again, we have most of the time lumbar region or leg presentation. They are associated with the asymmetrical weakness of the limbs with lots of pain, and there may be weight loss. This, if you do some biopsy and all, there are inflammatory microvasculitis causing ischemic changes to the nerves. Natural history is most of them they improve by themselves, but there are no incomplete improvement is the usual rule. Various immunotherapy had been tried with good results, and this is a paper they have tried with good result, but surprisingly there is no as such, there is no even though this is very common, there is no SS randomized control trial to prove that immunological manipulation is good or not. In this review literature, we cannot find any of the randomized control trial. So bad thing is that thing. So it's, you have to take your own decision. My opinion will be, if there is severe involvement, you have to treat with immunological manipulation. Mostly we treat IVIG, but still in India like that we can still go for steroid therapy. Then the symmetrical form of this diabetic amyloidopathy, mostly they are CIDP kind of thing, but this again CIDP is again there are very much diabetes is one of the risk factor for developing CIDP, and this thing there are correlation. So almost 9 times, 9-fold increase in the prevalence of CIDP in the diabetes has been shown in the population studies. And more importantly, CIDP is under-recognized in diabetic patient because of the associated other neuropathy. So we should always take into account or any neuropathy, severe neuropathy, CIDP should be again considered in the symmetrical neuropathy, like because they are treatable. So diagnosis should be like progressive symmetrical or symmetrical asymmetrical motor deficit, progressive sensory neuropathy in spite of optimal diabetic control, unusually high cerebrospinal fluid protein level in the diabetic neuropathy should alert the clinician to the possibility of underlying treatable demyelinating peripheral neuropathy in diabetes. So start suspecting, the suspicion is very, I will take any severe weakness should start investigating for diabetic CIDP. So diabetic patient with progressive polyneuropathy should be investigated with nerve conduction study to rule out this CIDP. Treatment-wise, CIDP, as we all know, it's immunological like corticosteroid treatment, plasma exchange, IVIG. In diabetic CIDP, very few studies have been done, and probably IV is the treatment of choice in the Western world, in Western literature. This is this paper showing it's a Cochrane database. They have collected all the diabetic CIDP patient, and only 50% had been treated properly with this thing, and almost 25% of the cases of diabetes CIDP was missed out, and there was progressive weakness in this. So this actually we have to identify, even in the Western literature you have this kind of almost 25% is not treated or left untreated. So we should be aware of this condition. We should treat because it is very amenable to treatment. The only few case report in Western literature, they have they are using mostly IVIG. So only few case reports are available to treat this for less costlier steroid or other immunomodulation. So in RIMS we have started, we have done one single blind case control studies. Actually we put on more patients, but for evaluation purpose we had only 20 patients, and they have been treated with short course of oral steroid and for 6 weeks, and evaluated with neuropathic impairment scale and visual analog scale. The study shows significant improvement in the study group on both the scale measures. Hyperglycemia can be monitored and can be treated easily. And this is, surprisingly, this is the largest case series been treated with the oral steroid, and there is no case control or any study available in the diabetic CIDP neuropathy. And these are the, we have done this thing. There are neuropathic impairment scale has been improved very much, and there was very much p-value is very much significant. Mass scale also very much this thing. We have I have also presented it with this was done in 2019. I presented in American Academy of Neurology meeting, and this has been I mean very much recognized. They have asked for to send the full paper also. So another group of neuropathy. So all this diabetic neuropathy is always there are very few case studies only, case series only. There is no randomized trial, proper trial is not done. So very few literature you could see in the this thing diabetic neuropathy treatment. And another group in the group 2, what we I was talking is the treatment-induced neuropathy, which maybe because of the insulin, especially insulin, there also their pain is very severe. Then the steroid is again one of the treatment of choice in this condition also. Other people have been trying lots of molecule and all, so there with no good result. Lately on the research this thing, they are trying neurotrophic factors, growth factors, gene therapy and immunotherapy, polymerase inhibitor. All this had been trying with no good result till now. Resveratrol had been trying, but still the effect is very less. No randomized control trial has been conducted till now. And lastly, my take-home message is any patient with diabetes develop progressive neuropathy, even with good glycemic control, should investigate with proper clinical evaluation and investigation, especially with nerve conduction study, and at times, if necessary, CSF examination to diagnose demyelinating form of neuropathy or asymmetrical neuropathy, for they are mostly treatable with immunological drugs. That will be my take-home message. Thank you.
Thank you, Dr. Suresh, for your nice presentation. Let me ask only 2 questions. Have you treated any diabetes-related CIDP at RIMS and with IVIG? And then after that, have you ever done? Have you checked with NCS now conducted study in case of conduction block or like distal latencies and all? And have you proved that there is improvement with IVIG?
Of course, IVIG is the treatment of the, as for now, IVIG is the treatment of choice. But my belief was always I am not very not very keen to use. It has been using before. In my AIMS days also we are using IVIG. But after coming down here, I've never, maybe 1 or 2 cases I must have used. But I don't encourage using this IVIG. So I started using steroid. And till now, lots of patients, almost all the severe diabetic neuropathy, I am using steroid, oral steroid, all severe neuropathy. Except for those kind of painful neuropathy, I don't use it. For those difficulty, once my humble request is always patient if they develop more weakness like difficulty in nursing, you should give a trial of oral steroid. And we have whatever our RIMS trial, we have done the check nerve conduction studies also after the oral steroid treatment. Maybe after 2-3 months we have done, and it has shown. And we have, I didn't show the full studies. We have done that in that also. And for study purpose, we didn't in that paper we didn't include because it was only 6 weeks studies. It was PG thesis. So we didn't do that time. Nerve conduction study is not available in this. We don't want to show nerve conduction study in that. But the actual thing we have done is nerve conduction study. So it was unethical to do nerve conduction study at that time. Now we have nerve conduction study in RIMS. We could safely this thing. So that time, though we have done nerve conduction study, we didn't show nerve conduction study in the PG thesis. There was this thing. All the patients we have done nerve conduction, plus after treatment per 3 months I repeated. It has shown very good improvement.
Thank you. The topic is open.
Dr. Suresh, excellent presentation.
Thank you, Tam.
Thank you for coming to my conference. But really, you are an enemy to me and to Ranbir as well. I think you are giving steroids to treat diabetic neuropathy. I think I am facing lots of problems. Please explain to me and to the mass why the steroid is the first line of treatment for diabetic neuropathy. Because it's all known that steroids will increase the sugar levels. If at all, if you have any clue, then clarify. Because I am facing problem. Ranbir himself is facing lots of problem treating hyperglycemia because of steroids. Tell me, please convince.
Actually, in countries like India, giving immunoglobulin, that too, like every 6 months you have to give, it costs around 3 to 5 lakhs per dose. And that too, you have to repeat every 3 to 6 months like that. It's out of question of choosing immunoglobulin. So we try to find out the cheaper options, which we have proof also. I have presented also. It was published also. So and we in all the 6 weeks studies we have control our diabetes. We go for those who have been taking oral hypoglycemic also. We convert to insulin and we monitor the insulin. It's controlling diabetes is not a big thing. I mean, don't mind endocrinologists. I mean, you increase the insulin dose, what is there? Why patient, I have been seeing lots of patients suffering from neuropathy untreated, left untreated.
Correct.
Even this very, they have put up, they have collected around this, search around 10 lakhs, this thing, CIDP patient, and 25% left untreated. I mean, this is a big number, and I think almost 80% left untreated in diabetic neuropathy. We see lots of diabetic limping, they are coming, jing and all is okay. But एक बार limping start हो गया, you should think of treatment. I mean, it's not only the pain neuropathy, painful neuropathy is not a, that's why I'm not covering here painful neuropathy. So those who which is treatable, we should try to find out the cause. And, any patient who develop bad neuropathy, you should investigate for this treatable cause.
Thank you. Thank you, Dr. Suras, for your excellent presentation. Of course, there will be compromise in the treatment from all sides. Thank you very much. Now we close this session, but we are already late by 1 hour. Thank you all.
Thank you very much. On behalf of the organizing committee, would like to extend our sincere gratitude to the chairpersons for skillfully guiding the session and to our esteemed speakers for their enlightening and thought-provoking presentations. Before we end this session, we'd like to call upon all the speakers to give us a moment to honor and felicitate you. First of all, to honor our respected speakers, we'd like to request Dr. M. Kulachandra Singh, former professor and head Department of Medicine, RIMS. Ikai Kunajariba Dr. M. Kulachandra Singh, Sarna Stesta Amutang Linkat Piraktuna, Aikogi Ikai Kunajariba Speaker Singbo, felicitate Amadi honor Tobinaba Nolukchari. First of all, would like to request our very first speaker, Dr. Maibam Bobby Singh, your presence on the stage, sir. Morning, sir. Matanda Ani Suba Ngasigi, first scientific session gi speaker, Dr. R.K. Banashri Devi, Ma'am Sulenkat Piragnaba Nolukchari. Ahum Suba speaker, Dr. Rajesh Waikhom, Lingshin Virakani Matanda. Aroiba speaker, House paper present Tobiramba, Dr. T.H. Suresh Singh. Sir Sulenkat Piragnaba Nolukchari. Matangda, Dr. R.K. Banashri, hematological changes in diabetes. Topic asida paper present Tobiramba Thagachari. Thank you very much. Matangda, Dr. Rajesh Waikhom, novel therapeutic for DKD. Topic asida paper present Tobiramba Thagachari. Thank you very much. And next we have Dr. T.H. Suresh Singh, who presented paper on the topic treatment of diabetic peripheral neuropathy. Matanda Ekogi, respected Chairperson Singh, felicitate Obinabagi Damakta, Dr. Dhanraj Chongtham, DM Cardiology, Professor and Head Department of Medicine, RIMS, Sarvunolukchari. Dr. Dhanraj Chongtham, DM Cardiology, Professor and Head, Department of Medicine, RIMS, Kausanjari, Loinana, Dr. M. Kulachandra Singh, Sarbusu, Thagachaba Fongdokchari. And respected Chairperson Singh, Dr. I. Anil Singh, Dr. T. Brojan Singh, Dr. Khetrimayum Manglim Singh, Dr. M. Ratan Kumar Singh Amade, Dr. K. Romeo, Ikai Kunajariba, Chairperson Singh, Matang Lingshin Biraknaba, Nolukchari. We have a respected chairperson, Dr. Khetrimayum Manglim Singh, Senior Consultant. Thank you very much, sir. Mathangda, Dr. I. Anil Singh, DM, Hematology, Professor, Department of Medicine, RIMS. Thank you very much, sir. Mathangda, Dr. T. Brojan Singh, DM, Nephrology, Professor and Head, Department of Nephrology, RIMS. We have Dr. M. Ratan Kumar Singh, DNB, Neurology, Professor, Department of Medicine. And also would like to request Dr. K. Romeo, our respected chairperson, sir. And would like to request our respected speakers once again for a group photo session. Dr. Maibam Bobby Singh, Dr. R.K. Banashri Devi, Dr. Rajesh Vaikom, and Dr. T.H. Suras Singh. Your presence on the stage, please. Masigi mathangda anisuba. Yes. Would like to request Sir Kula for a very quick group photo session, as we are running a little late by the schedule to start the next session, that is second scientific session. The topic is updates on management part 1, and our respected speakers are Dr. Vikash Bhattacharjee, Dr. Taruni NG, and Dr. Mridul Das. So to begin the next Mathangani Suba scientific session game, Chairperson Soina Lingshin Bigadawa Ikai Kunajari Basingna, Dr. M. Kulachandra Singh, former Professor and Head, Department of Medicine, RIMS. Mathangda, Dr. Dhanraj Chongtham, DM Cardiology, Professor and Head, Department of Medicine, RIMS. Mathangda, Dr. N. Kameshwar Singh, Pediatricians, Professor and Head, Department of Pediatrics. Mathangda, Dr. N. Suraj Kumar Singh, DM Gastrology, Managing Director, ILDS. Dr. N. Kameshwar Singh, Sabusu Koksinjari Loinana, Dr. N. Suraj Kumar Singh, DM Gastrology, Managing Director, ILDS. Now I would like to hand over the mic to our respected chairpersons. Ladies and gentlemen, our respected speaker, Dr. N. Suraj Kumar Singh.
Hello. Check.
Yeah, a moment, sir. Yes. Dr. N. Suraj Kumar Singh, DM Gastrology, Managing Director, ILDS, Sarasi, hakchanggi kitang unavoidable oiba situation ama lakpana maram oiraga ngasi thoramasi saruk yaba ngamdre haiduna mayamgi mafamda magi apology thambirei. So he sends his apology to everyone as he is unable to join this conference due to some health issue. Thank you.
Good morning, everybody. Actually, in this session, we'll be having topic on diabetes. The speaker is Dr. Vikas Bhattacharjee, but because of his health condition, virtual. Okay. To be virtual presentation. Dr. Vikas Bhattacharjee is a senior consultant diabetologist in Guwahati. Now, Dr. Vikas Bhattacharjee, please.
The epidemic of diabetes that is happening now is actually now and Dr. Ochuba, can you are you here? Can you see my slides? Hello, can you see my slides?
Your slides are not visible here.
Not visible?
Hello.
Is it visible now?
Where is that?
Slides are visible? Yes?
Yeah, it's visible here.
Yeah. So, my topic is management of diabetes. And this term, the term diabetes was coined by Sims et al. To describe the very strong clinical link between diabetes and excess body weight right back in 1970s. Visceral adiposity, which leads to insulin resistance, is the putative mechanism in the development of diabetes. Therefore, an ideal treatment strategy for the disease will also include optimal management of obesity. So it is not only treatment of diabetes, also obesity has to be treated. Diabetes is rapidly growing social challenge worldwide. There is 783 million. Anyway, in that study, 46% patients with intervention and greater loss weight led greater proportion addition and weight was very high, when have a 6% and like that a lesser weight different placebo one of the patient can without medicine. So these are comorbidities we address today in that very important. Hypertension, OSC, studies, and hypertension and coronary artery disease, diabetes. Now, what's called the all these things have been developed and weight loss concept real benefit. And what is the evidence-based approach to lifestyle and diet behavior? Diet and physical activity is important. Behavioral therapy is absolutely important. And the drug also in the early step, reluctant to use them, but taking them for treatment is not probably will become. And those are something that we will talk about the excessive testing plan, metabolism testing plan, women and wine testing, now, our point is very important. Effect of controlling independent whereas the typical with the alpha insulin suffering the nitrogen diet and albumin so first comes metformin. Effect of intensive blood glucose control metformin on population is overweight from there, after that, if they say you may not use so then of course from the GLP of course comes by GLP-1. GLP-1 is a prevalence, one way is furthermore, they modulate receptor of the blood regulator as well as human involvement. They stimulate aromatase in our food. These mechanisms help to reduce the appetite. GLP-1 receptor agonist first time injected into the consideration in larger while also resulting in acidic cardiovascular and also enabling you know how it works with increased appetite, that increased time, it stimulates insulin release and reduces metabolism. Glycogenolysis and also releases in this is the mechanical state. Now let us look at symptoms. Classically, symptoms as I consider one should look at the symptoms that are not safe. are good alternative options for patients with diabetes. We can use also acarbose. So I think I have come to the end of my slide. And just I'll go to the wonderful molecule that is the tirzepatide or trinitrotine, and there is a SURPASS study. And weight loss with tirzepatide in type 2 diabetes. And you can see, compared to placebo, there is a weight loss of 9.5 kilo. weight loss, 1 milligram, and with tirzepatide there is 12.4 kilogram weight loss.
For the privilege and honor given to us to share these sessions, and I am being from pediatrics. I am really thankful to the organizers. For this second topic, I would like to call upon my senior PG alumni from PGI Chandigarh, Professor Taruni Ngangbam, former professor and head Department of Medicine, NEDS. She is a well-known senior diabetologist and geriatrician, and also live member of RSSDI, API, and GSI. And Madam is also holding the post of Vice President, GSI Eastern Chapter. So, Madam, please, the floor is yours, Madam. For this topic, vaccination in diabetes, update.
그노네 그게 덱스업다 판대 여부도 아주
Sorry for the inconvenience. We have some technical problem, so we would like to take up the third speaker first. And for this, I would like to invite Dr. Mridul Das from Agartala to take up his topic on role of gut microbiota in the management of type 2 diabetes mellitus. Dr. Mridul Das, are you ready? Not connected. He is doing virtual from Agartala. Audible? Please show your slides. Microbiota. Role of gut microbiota.
Role of gut microbiota.
How to find my slide here? This is Windows entire screen.
Not yet visible, sir.
which causes metabolic dysfunction and hence type 2 diabetes. And I must say in diabetes, everybody has got different type of microbiota and variations are there. And the person which is suffering from diabetes is gut microbiota is something else. Who is suffering with a very high load of sugar level, blood sugar level, this the gut microbiota is something else. So by the type of gut microbiota and analyzing the organisms, we can predict diabetes, which will be very bad in future or will be controlled in future. So this is very good biomarker of prognosis in diabetes. This we have already told obesity how it increases inflammatory cytokines and causes diabetes. And anti-diabetic drug. These drugs actually vice versa. It can modulate the gut microbiota and also gut microbiota can modulate the activity of anti-diabetic drugs. So some drugs are very much efficacy is potential and side effects following the administration of anti-diabetic drugs and also influenced by resident microbiota. The presence of certain generous species food predict whether subjects will experience side effects as well as response to probiotic supplements. This is a slide which says the bidirectional interaction between gut microbiota and anti-diabetic drugs. Anti-diabetic drugs can modulate gut microbiota can modulate the function of anti-diabetic. This is nothing but we have already told. And gut microbiota and metformin very beneficial to improve the quality of gut microbiota. This can increase good bacteria in gut microbiota and decrease other pathogenic bacteria. Also, metformin promotes short-chain fatty acid production, which is good to prevent diabetes, and also protects the intestinal barrier, which ultimately is beneficial to pass through the inflammatory cytokines, which can cause destruction of beta cells and prevent this diabetes. And which also, metformin also regulates gut peptides, which is good to prevent diabetes. So therapeutic value of harnessing gut microbiota is very essential, that combining drugs with healthier diet and less sedentary lifestyle, the gut microbiota becomes very harmful and unhealthy, while when a healthy gut microbiota is there and with this lifestyle modification and with a proper diet, healthy diet, this gut microbiota becomes very effective to prevent diabetes, its reversal and lowering down the sugar level. So gut microbiota actually is of different types: enterotype 1, enterotype 2, enterotype 3. Enterotype 1 is bad, diabetes, into type 2 is good for diabetes, and to type 3 is neutral for diabetes. I'm not going to tell all details here. And prebiotic probiotic administration. This is required when gut microbiota is unhealthy. What is prebiotic and probiotic? Probiotic actually the live microorganisms which is found in gut microbiota and which can be treated, which can be given as therapeutic method to increase the healthy gut microbiota. And what is prebiotic? This is the environment and food to provide the probiotics, the live organisms to become, to make a good microbiota. So prebiotic is the environment and probiotic is the live organism. And how these probiotics are extracted and given as therapeutic method? This potential probiotic bacteria is identified, then it is isolated, then it is cultured, then it is processed, and then it is finally given to the patient to improve the gut microbiota. And something about fecal microbiota transplantation, that is FMT. This is, of course, looks like a very crude method, but very, very effective when the probiotic prebiotics preparation cannot give us a good microbiota. That this fecal microbiota transplantation is very much beneficial, and it is these days practice. It is fitted through gelatin capsule preparation, and but we must keep in mind that it should not transfer any infection and promotion of this biotic status. So, substantial evidence suggests that gut microbiota and the metabolite it produces are critical to the etiology of diabetes. A good gut microbiota is beneficial for prevention, delaying, and reducing severity, even reversal of type 2 diabetes when combined with medication, exercise, prebiotics, probiotics, and identifying specific microbial metabolites responsible for the pathogenesis of type 2 diabetes to provide interesting new opportunities for the diagnosis, treatment, and prevention of type 2 diabetes. The field is totally unexplored. There are several studies are there, several research are there, but still this field is unexplored, and how to get a good microbiota and how to prevent diabetes, that can be again research and study is required. Thank you very much. This is Agartala city. I am from Agartala. Thank you from my diabetes clinic. Thank you all.
Thank you so much, Dr. Das, for your elaborate talk on microbiota in relation to diabetes. So,
microbiota is a known fact. I think most of us will agree to it. If there is some change in the gut, there will be hyperglycemia and everything. So, from my side, let me say, but Sir will also be, our professor is there in front of us. Professor is there. If something is changed to develop this microbiota, kindly please, excuse me.
I just want to say, this, if we have very good microbiota, this good microbiota can produce different types of metabolites, which is beneficial to prevent beta cell destructions and also to prevent insulin resistance. So everybody must have a good gut microbiota to prevent diabetes who are having genetic history or any obesity or very prone to diabetes. They must maintain a good, healthy gut microbiota, and for this diet, exercise, those things must be maintained well.
Any more comment, any more questions regarding the topic?
Sorry to come back once again. Diabetes comes up, and it is all about gut and diabetes and pancreas. When gut is at fault, then it's audible. Is it audible?
Audible.
Okay, okay. If gut is at fault, then we are working through some systems of diabetes. If I'm not wrong, this is diet, gut, kidney, liver, and skeletal muscles working together. If one of the system is at fault, then there will be derangement in glycemic control, and this is what we are facing all about. And the consequences of kidney, then heart, then the kidneys will come up. If microbiota is at fault, the absorption of the glucose from the gut may be at fault. How to improve that? That is the crux of the treatment, the crux of the deliberations, I hope so. So how will you improve, and how will you improve to prevention of glucose from the diet to prevent diabetes? Miru, please. Yeah.
So, because of some technical problem, it is very difficult to communicate. Once again, very much thankful, Dr. Mridul Das, for your elaborate presentation. Thank you so much.
For the next session, we have a slide series in the program started from the first from the 19th side. Professor Tarun is speaking. JNIMS, Director of Diabetic Food, Surgeon Department of Diabetic, Lead Complication and Care, and Valley Hospital, Assam. Then request Dr. Sudhir Kumar Jain.
Yes, any answer? Is high. Not quite sure. This is the Joe Sydney. Fine? Yeah. What's that? Can you just speak? What is the full screen gone now, my dear? In the main screen, there should be full screen. वहाँ पूरा होना चाहिए ना? And if an amputation develops, it is far more than a cancer mortality at 5 years. So it is a tremendous problem. If you think of the cost, do you think it is less costlier than cancer management? No. It is more than the cancer management, the costlier. So we are going to talk about the conditions which is least spoken least known, least discussed in the conferences, and it has to be understood. But if you think of the primary level services that are available in the entire Northeast and maybe in the most of the part of the India, they are very negligible. Not to think about the tertiary centers, the super specialist centers where the diabetic foot is managed. Now, if a person with diabetes develops diabetic foot infection, what are the options he had? Fine. With Googleopathy, he will search in the Google and find out that I have an ulcer in my foot. What will be the best treatment? Or I am having less sensation in my foot. What is the treatment? This is what we call Googleopathy. So what he will get? One pair of acupressure sandals, okay, or some acupressure mats on which he will start doing vigorous exercises, and he will damage his own neuropathic insensate foot further. Or he may ask some of his relatives that I am having less sensation, what to do. Somebody may ask you to do a lot of vigorous mustard oil massage, keep hitting, and go on walking as much as possible. He may go to a parlor or barber to get his deformed nails pared, and this may result in damaging the pulp or the finger or the toes, ultimately leading to what we call the sepsis. Because there is no sensation, and a parlor boy or a barber doesn't know how to cut the deformed nails of a diabetic patient. He doesn't have the instruments. He may go to a compounder with dresser because everybody thinks that if the ulcer is there, a compounder is good enough. He will do the dressing and he will cure me, which never happens. He may go to an orthopedician because he is having heel pain, and that heel pain is because of the sepsis, and orthopedician may think it is a painful heel syndrome, what we call plantar fasciitis. He may inject what? Injection tricot, and he may force the patient to go into sepsis. Dermatologists may be consulted because they are having cellulitis, having redness of the skin, itching of the skin, underlying there is a sepsis. A dermatologist may think it has a simple, dermatitis. He may write some emollients, some moisturizer, and the patient will be sent to what you call he will be Dumbo-like in thing. He may go to a general surgeon, having an ulcer. He may think it is a dressing work. He will write few antibiotics. He will ask few investigations, CT, MRI, and whatnot, and he will ask the patient to go and get it dressed by a dresser. So this process goes on continuing without any permanent solution. Similarly, diabetologists may be consulted. A person who is having diabetic foot sepsis, having high sugar because of the insulin resistance, the physician will try to control his blood sugar tightly, wasting few weeks and months. He is having sepsis, he is having insulin resistance, and that's why the insulin, the sugar is spiking high. But the time will be wasted by that physician who doesn't know what is sepsis in diabetic patient. So this is the scenario that is prevailing in our country and especially in Northeast, I can say. What are the primary level centers we have in diabetic foot management? Including medical colleges, I should say they are all primary centers, primary level centers. Why? A person who is busy in managing the accident cases, managing a perforated duodenal ulcer, managing a burst abdomen, he is also forced to see a diabetic foot patient in his busy OPD. Doesn't happen in the Euro centers? Yes. So even the medical colleges, I should admit, they are working not as a specialized centers, as a tertiary centers, but acting like a primary level centers. There are very few tertiary centers that may be there in all over the India who are doing exclusive diabetic foot work. with a team comprising of various disciplines, various doctors. The patient is fixed and he is managed in a proper way. So just to say that we are having very least number of tertiary centers all over the India. And this is what happens. In a busy medical college, in an institute, when a patient with diabetic foot will go, he's having multiple problems, multiple system problems. Somebody will say, you are having an ulcer, go to the general surgery. No, you will need plastic surgery. That ulcer which is infected, rotten like anything, somebody wants to go to plastic surgery, they will manage it. Because you are having osteomyelitis, you go to orthopedics. No, you are having the peripheral arterial disease, you go to the CTVS, endocrino, cardio, nephro, neuro, whatnot. So this is all in one. And all the departments that poor fellow will go on moving around, trying to find out the solution of this problem, diabetic foot. And one of my patients who was having sepsis, who was saying that I am having some problem, having fever and all these things, but nothing was clinically appreciable. So somebody asked you to go to the psychiatrist because you don't have any problem, still you are coming here. This is a fact. Because of neuropathy, because of less of sensations, the person who is having suffering, he doesn't have any pain. So no pain, no examination, no treatment. So this is what we call footballing with a diabetic foot patient in an academic institute. And this is the operation theater operation list that we prepare for a diabetic foot patient. Get to the last, a person who is fasting since morning, having sepsis, having no pain, that's the only problem. Okay? He's been kept to the last in the operation theater list to be done, to be operated, to be seen by the junior most staff, and to be done under local anesthesia without any assistance. Is it not a fact? It is a fact. Yeah, because I have served medical colleges for 25 years and I have seen all these things happening. A sister will come with a ball of few dressing materials, give it to you and you will run away. Sir, आप ये क्या गंदा काम करते हैं? And most of the time in the private sector when I started working, I was supposed to visit that hospital, the OT of a nursing home in the night hours when all the laparoscopic work, endoscopic work, lab police have been finished because once I do this work, nobody can use the OT because it becomes totally void. So I was called once upon a time, Ratri doctor, Raat ka doctor, night watchman. So this was when I started 20 years back. If you see in the genesis, there are around 100 million diabetic patients and 130 million pre-diabetics. And if you consider the foot, the number of feet, they are double. Fine? One person having 2 feet, so they are double. So many feet are at vulnerable position, having neuropathy, loss of sensation, which has to be said. And if you see the vasculopathy, the macrovasculopathy, what you call, which is called that it starts before the diabetes starts. It is irreversible, but it ultimately leads to the chronic heart disease, cerebrovascular accident, and PAD. Now, if you can diagnose a patient having diabetes at that stage and start some of the preventative medicines, can't we stop that later on the problems of the foot? And similarly, the microangiopathy, what you call, that is, we can control it. We can control the diabetes well and we can probably prevent the development of early neuropathy. So everybody knows that these are the important organs to be seen in diabetic patient when it comes to the clinic. Yeah? The thing which is always forgotten is the feet. Am I wrong? Everybody will think heart, kidney, brain. Yeah? say in a duration of about 4 years, a person who was having just insensate foot, senseless foot of neuropathy, why he has to undergo an amputations in after just 4 years. The foot was with us. The patient was coming, nobody checking, nobody touching his feet, nobody aware of him that you are having insensate foot, sensory neuropathy. Take care of the feet. Nobody has asked him. And ultimately this has happened. Who is at fault? We. Okay, now let's see what I am going to present here. What is the present scenario and what we expect. The present fact, I am working in a hospital which is almost like a tertiary centers. Most of the patients when it comes to us, they come after an interval of about 15 days to 365 days. The ulcer, the infection, the sepsis started about 3 months back, 4 months back, and they come to us at that stage. Most of them come in a higher stage of infections. And most of them, they don't have any foot care knowledge. Though most of them were attending the physicians' clinics. Yeah? Now what is the trap? As a patient has got senseless feet, he doesn't have any pain, so he doesn't ask a physician to check his feet. He doesn't say I am having any problem. He may be having severe sepsis, he may not be having any pain because sensory neuropathy. He may be walking to your chamber on his own feet. So when there is no complaint, there is no action, no advice. Why a physician, why a surgeon should go and check his feet when the patient is not saying that anything wrong in his feet? He may be having high fever, he may be having high creatinine, he may be having high blood sugar, he may be having nausea, vomiting, of sepsis, but he doesn't have any pain in the feet. That is the origin site. And that is the problem actually we have. No complaint, no examination. Then this field is very, not that lucrative, no? Less interest in this field of diabetic foot management. Who will see it? You do a laparoscopic surgery, put few thousands rupees in your pocket and go away. So that's the problem in diabetic. Now there is MRF, you must remember. We miss the feet at risk. When the foot problem just started, we don't diagnose at this stage. Most of the presentations are misleading type of. Having fever, having anorexia, having high blood sugar, having high kidney and creatinine. So these may be the symptoms of a diabetic foot problem, sepsis. Now we too much rely on diabetic blood sugar control. Patient may be having high sepsis, having high sugar, and the physician will try to control his blood sugar before he refer it to a surgeon. Do you think it is going to help the patient, or you will have a success in this direction? Or we try with antibiotics, ointments, and we usually forget there is a team behind us, having surgeon, having orthopedician, plastic surgeon, all we usually forget. We forget to offload, giving rest to a septic foot. That is a big treatment we have. And we usually forget there is importance of doing a proper source reduction. We don't refer. We usually forget that peripheral arterial disease is rising in Northeast also, and we don't know about what is Charcot foot. So this person is an example. He is being examined, investigated, but nobody touched his feet, nobody advised about his feet problem. So full of investigatory papers and all. So what is the solution? The solution is, we are mostly directed towards a treatment, okay, which costs around 1.5 lakhs, 2 lakhs, 3 lakhs when the infection, when the foot problem already has gone up. But we forget about the prevention, which costs how much, you know? Just 1,000 to 1,500 rupees annually. If you can prevent at that stage, which may cost us 1,000 rupees a year, we will be sparing so much of, the financial problem of the patient. So rather than investing money in treatment, why not you invest something in the prevention? So these are the feet at risk. At this stage, if you can detect, diagnose, advise, treat, the problem will not go to the stage of sepsis. But usually we forget this thing. These are the main culprits. There must be a breach in the skin, a cut in the skin, produced by any of these organs, any of these agents, and through this breach, through this cut, the infection will go inside, it will produce sepsis, patient will not have any pain because he is having neuropathic, and then the problem starts. Can't we, as a physician, as a surgeon, when the patient comes first to us, say that you are having an insensate food, please take care of our feet from all these agents. Behind every diabetic patient, if you go asking how it happened, they will say, I don't know, sir. Aise apne aap ho gaya. Nothing happens apne aap. Nor it is God given. They are the agents which creates a breach, scheme, and then through this breach the infection enters. And that leads to the infections, and that is the problem. So can't we ask the patient to take care of it from all these agents? Very easy. So if there is no gate of entry, if there is no gate of a breach in the skin or cut in the skin or anything in the skin, there will be no problem. This is what happens. In a full-blown, high-grade diabetic food, we try with antibiotics and ointments. Is it going to help the patient? No. What is needed is the surgical source reduction. If you do the surgical source reduction properly, at proper time, we can save the patient's life, fit, and lot of financial burden. But this is very rarely done. And we usually forget that giving rest to a diabetic patient itself is a great treatment. Ask him to take rest, offload the food. That is a great treatment. Go on walking means go on pumping the infection inside, spreading the infection inside without the knowledge of the patient. He doesn't have any pain. And we don't refer the patients timely. So always start your examination from your feet. When a patient enters to your clinic or in outdoor, touch his feet, starts examination of a diabetic patient from his feet. Okay, that's very important. You will get a lot of information. The impression or the importance of the feet is only recognized when you start your examination from the feet. The patient will understand that a professor of the institute, he is touching my feet, there must be some reason. I will try to keep my feet as healthy as possible in the future. So this is our attitude. Touch and welcome the patient rather than doing a handshaking. This is a project on which I am working, Project JNIMS. It is there in the Facebook also. So touching feet is a Hindu, there's a religion. So once you touch the feet, we can diagnose a lot of early problems like fissure, cracks, callousness, wordness, swelling, deformed nails, fine? And they are the forerunners for the sepsis. So start touching feet. Start doing JNIMS first. Okay? And remember, diabetic foot management is a dedicated full-time job. Like a student person, no? Not a part-time, time-pass job. I am doing laparoscopic surgery, doing endoscopy, I am doing diabetic foot surgery also. This is not going to help. Now just to summarize, when to refer to higher centers? If there is a higher grade of diabetic foot, unstable comorbidities, metabolic hemodynamic instability is there, systemic toxicity is there, peripheral artery disease is there, what is called necrotic fasciitis you doubt, complicated Charcot foot is there, corrective surgery needed, lack of expertise is there, and lack of facility. Under these circumstances, you please refer the patients to a center where this is being done. The primary level personnel has got a great role to play in the diabetic foot management and prevention. The basic foot examination, basic foot care advices, foot care educations, basic foot wear advices, creating public awareness, detecting feet at risk and treat them properly in time, basic diabetic foot treatment, timely referral to higher centers, follow-up care and prevention. So all this thing has to be done by a primary level person. Then there will be no role of a person like me. There will be no diabetic problem, I will be going and taking sannyas. So a very good thing that is happening, that has happened in just few months ago, a molecule called dialkes. This is a local topical gel which can be used. It is actually antihypertensive and it is a selective beta blocker, but this has come out in a gel form now. And this is a very useful molecule, and if you see some of the results, you see that in 12 weeks a marginal ulcer is free. Fine? Another example you can give is the dorsum of the foot ulcers. Dialkes is a topical gel which is actually a derivative of antihypertensive, a research product. You can see the plantar ulcer is healed totally. And this is how a dialkes actually do the healing mechanism is there. Fine? But if you have to conclude, it is safe to reduce the pain and the discomfort if you use a dialkes. It is user friendly. It is work considerable at a primary level. And it can be used at the primary level as well as those ulcers which has been downstaged, those who is improving now. And it is useful while waiting for the definitive intervention. You have to go for a plastic surgery, SSG graft, you can start using this one. And useful for patients not fit or not willing to undergo any plastic repair. There we can use. But must remember, it is not a panacea of a diabetic foot ulcer. Offloading, giving rest, glycemic control, nutritional support, stabilization of the comorbidity are very important. Secondly, if I say being a surgeon, the best antibiotic and ointment that we have is a knife in the hand of a good human being who is also a surgeon. So don't go like that, okay, this ointment has come, now this will help. No, this is not going to help. You have to prepare the bed, you have to then use and then you will find results. And one question that I'm still having, that whether this dialkes molecule, the newly launched, is going to help in higher grades of, So this is what we do in my hospital. There is a temple called foot temple. Have you ever seen it? Ever seen? No, you should admit, na? So we worship. There is a temple where the patients goes, where the attendant goes, they worship foot and they start knowing that the importance of the foot in our life. So to end this simple and most ground level lecture, we must remember the 3T in diabetic foot management. We should think about a diabetic foot. There is an entity called diabetic foot, not food. Second, we must start talking about diabetic foot. With every 30 seconds, one amputation is going on. Okay? And we should start touching the foot. What is called Charan Spars. So this is in the Facebook page also. If you go to Charan Spars, you will find it a lot of motivational things has been put there. I had few books written, one book written in Hindi and Assamese and English translation is going on. If Ashoka Singh and somebody asked me what I can do, I can send a few books written in Hindi at least at this point to this institute to be used by your students and by the patients. If you permit, English translation is almost is going to be published soon also. So that's conclude my lecture. Thanks once again for a wonderful this organization that I mean, this is the first time I came to the IMPHAL, and I really enjoyed it. And thanks very much. Thank you.
Thank you, Dr. Sudeep. Once again, we really thankful that you are coming all the way from Guwahati to IMPHAL for this conference. We really welcome you here. Your nice presentation also, very interesting. Before I open the topic to the House for discussion, I'm just wondering, how is this more useful in the healing of your ulcers, in the diabetic ulcer? That's one thing, that the ointment that you're talking about.
Now please remember, this is not a panacea. This is not the thing that has happened for the first time. There are many ointment comes and goes. The first thing is that this is useful if it is grade 1. University of Texas means the superficial ulcers, not the deeper ones. That's one. It should not be clinically infected. It should not be clinically infected. It may be little ischemic, of course. That is 1C. And that's ABI, that is ankle brachial index, should be more than or equal to 0.65. Now you see that many times what happens when we start our journey and there is a gross infection and all these things, we have stepped it down to a more healthier ulcers. Now patient also wants to go home, okay, and wants to do the dressing at home. At that time, I think this is the best thing we can do, we can prescribe it. And secondly, all those ulcers which comes to you as a physician, the superficial ulcers, if you have already excluded that there is not a deeper ulcer, there we can start using this one. So it is very user friendly. Nobody, you don't have to, you will lose your consultancy. Fine? Don't you? The person who is coming regular to me and I am taking some money in my pockets, he will stay at home and he will do his own work. So that you have to accept. That means it becomes an opaque treatment, outpatient basis treatment. In that way we have seen it works wonders, sir.
But I was just thinking because if you see the literature, in Second World War, many of the injuries, they were all dressed with the phenytoin. If you remember, the wounded, the phenytoin ultimately formed some amount of healing proliferating actions. Is the smaller having same kind of property, or is it really a recommended drug? Or actually, to me it seems to be, I am not a diabetologist, but to me it seems whatever the picture you are showing.
Actually, I have already told you that there are some mechanism of actions. They say that it reduces the oxidative stress, it improves the angiogenesis, it increases the collagen formation and epidermal. Now already a lot of study has been done. Phase trial 3 has already been done and phase 4 trial is now started, is going to start soon. And what many literature you see the dialcus, if you put it there, you will find that everything is authenticated before launching into the Indian market. And this is one good thing, that this is in collaboration with Virat and with your one of the pharma company. What is that? I don't know. So this is a purely make in India product. It's not coming from outside and entering into India. But one thing, please, for my lecture, I will request you, rather than remembering diabetes, you remember there is an entity called what? Diabetic foot. So you please start knowing about the food. You can communicate with me. And I will always there, because this is the last innings of my life. In this field for last more than 2 decades. I am doing only footwork, nothing else. Left everything and in this field only. So anytime anybody wants my help, if you want to start one department here of the podiatry department or any of the foot leg and something, I am always here to help you. That assurance I am giving.
Okay. Such a fantastic talk you have given to NEDSCON 2024, and I'm enlightened. And you rightly said there is no medicine for diabetic foot, but it is the naive technical dressing I could be overheard. I think this is the instrumental for every PGTist. I hope so. What I'm also doing right now, being a diabetic healer, many diabetic foods, I usually take patients from surgical department as well. I used to transfer back to my department so that my juniors are made very busy in doing regular dressings. What surgeons cannot do, I think it's beyond our scope. I think they are also doing very good things. I'm not underestimating, but my own people are doing something like, it's all about preventing amputations last. Amputations in diabetic foot. If you do, out of 100, if you prevent diabetic foot amputations by 40%, this is your achievement, what I feel so. Forgetting about diabetic stress, control and everything, that will be done by many patients of at hand. I also suggest to the mass that diabetic food is not all control of sugar, but it is the best dressing you do. This is what you are doing is really appreciated, and I see from many aspects of the audience that good dressing is what is being required, and the grading 1 to 5, 1 to 6, according to WG categories are being taken care of here. I think your points are well taken, and it will be given to my students as well. And I think I don't use anything. I don't use anything for diabetic food because there are so many of my juniors present here. I don't allow any costly preparations, diabetic food. I don't need any costly medicine, antibiotics. But I suggest them that your hand is the antibiotic. Your hand is the is the antibiotic. If your hand is not good, then you behave as a worse, bad antibiotic. So I don't use. So if you can come to, if you once come to my diabetic ward, there are so many diabetic food. I don't use heavy antibiotics. I don't use. People will agree with me. That's why that's the thing that because their hands are diabetic. Thank you so much.
As the sir has already told, that 90% of your sepsis load you can control with your good surgical debridement and surgical source reduction. And regarding the amputation prevention, we always have an importance we give to a functioning foot theory. My lot many patients, those who are supposed to have a below-knee amputations, they are now walking with single toe, 2 toe, 4 toes, half foot. So it is not the cutting is important, the saving is important, and that saving may be 1 toe foot, 2 toe foot, 3 toe foot, or whatever foot. So that is a very important thing, message from sir, that try to prevent. Amputation doesn't mean that cut all the foot, no? You try to foot, and that is the actually challenge we have. Cutting takes 45 minutes. But you think of the person on whom we are operating. So always try to save, and that is called functioning foot theory. Save a foot which is walkable, which is useful. Thank you sir, very, very much. One more question.
Very well.
I am consuming time, and not just time, ma'am is consuming your time. And lunch and between you is ma'am is standing there.
So sorry for that. But I think you are doing a very good job, by taking up this diabetic foot treatment. Okay, as I am in this treatment of diabetes for the last many years, and when I was in the Department of Medicine, that time also I have come across with lots of diabetic food. Okay, and the problem is, like Dr. Asoka is very right, that it's a part of the prevention towards going to the severe form. But in many cases, we see patients with a very advanced stage of diabetic foot when all the compartments are affected and then all the tendons, all are affected. That time, it is very difficult for a diabetologist or a person who is dealing with the medical treatment of diabetes to manage diabetic foot, because at the end it has to be surgery. And for that, like bone is affected, tendons are affected, muscles are affected, then with the development of all these specialties, then, like muscular affected. And so it becomes so difficult for us. Like when we send to the surgeon, they will say that, okay, this becomes, affected, bone is affected. and so you have to discuss with the orthopedicians. Okay, then we ask them, then all the circulations are so much compromised and may not be when we operate, and he or she may not come out of it, and so and so forth. We face so many things, and that is why a person who deals surgically with only diabetic foot is a must in the treatment of diabetes holistically. So you are doing a very good job.
And ma'am, I won't like to take any share out of you. The physician is the captain of this multidisciplinary team. We are all the backbenchers. She will coordinate, or anybody who is physician, he will coordinate with the cardiologist, nephrologist, urologist, all these logists. So we always try to be at peace, but the things become reverse. We become the exposed person, that I am responsible for, sir, bilai khavo parimne. Do you know what is bilai? Tomato. So when the patient is going on the day of discharge, he will ask, sir, bilai khavo parimne? Well, there was a dietitian going to your room taking all the time fees. Doesn't he told you about this one? Sir, insulin ketia bondo korim. So you know that always I try with folded hands that you are the captain actually, Mahendra Singh Dhoni, and we are the wicket keepers and all this. But the things goes reverse. Every time we are exposed, and it's become very difficult because after doing all surgeries, this and that, and ultimately say bilai khavo parim. So that's too much for us. Thank you once again. Thank you very much. Lunch is ready.
There is no more question. Once again, we thank all the speakers for the nice presentations. Thank you, Dr. Sudhir. So we end this session here with the permission of the organizing committee.
That is the benefit I am getting out of there is a long barrier. I will be getting something.
Before we close this session, we'd like to take a moment to honor and felicitate our respected speakers and all our chairpersons. First of all, would like to request Dr. Taruni ma'am to felicitate our respected speaker, Dr. Sudhir Kumar Jain. And we extend our heartfelt gratitude to Dr. Sudhir Jain for traveling all the way to IMPHAL to present your paper, and your energy, your enthusiasm, dedication are truly commendable, and we deeply appreciate your presence and valuable contribution to this conference. And last but not the least, thank you so much for your unwavering josh. Thank you very much. Madam Namathamatang Chairperson Singh to felicitate the Viram Navachil.
To all of you, nothing your faith.
Thank you very much, sir. I'd like to request Dr. M. Purachandra Singh, former Professor and Head Department of Medicine, JNIMS. Thank you very much, sir. Next, we have Dr. N. Kameshwar Singh, Pediatricians, Professor and Head Department of Pediatrics. And also we have Dr. Dhanraj Chongtham, DM Cardiology, Professor and Head Department of Medicine, JNIMS. Thank you. So attention everyone. Yes sir, please. I have an announcement. So the winners of the poster presentation and free paper presentation will be announced during the valedictory session at the end of all the session, as we are left with only one scientific session. We request all participants to stay with us till the conclusion of the conference and join us for the valedictory program. for the next session, third session and last session. The topic we have is Updates on Management Part 2, and each talk is for 15-minute and 5-minute discussion. The chairpersons would like to request Dr. L. Amarjit Singh, Dr. C.H. Banikanta Sharma, Professor and Head Department of Orthopedics, JNIMS, Dr. Rajendra Thangjam, DM Cardiologist, Professor and Head Department of Medicine, JNIMS. Our respected chairpersons, Dr. L. Amarjit Singh, Dr. C.H. Banikanta Sharma, Dr. Rajendra Thangjam. I would like to hand over the mic to our respected chairpersons.
Okay, so we have the last session of the updates on management of diabetes, and our first speaker is Dr. Taruni. She will speak on the vaccination in diabetes mellitus. Dr. Taruni is a well-known physician in our state. She was the former professor and head Department of Medicine, RIMS, and senior diabetologist and geriatrician. She's life member of many other important organizations, including API, and the vice president of GSI Eastern Chapter. So may I request Dr. Taruni Nambam.
Good afternoon, everyone, and thank you, chairpersons. My topic, vaccination in diabetes. Why vaccination in diabetes? We all know that diabetes is one of the very common problem in India. It covers about, say, more than 10% of the population in India, which is about half of the children population of India. And the prevalence of infections is more in persons with diabetes than any other persons without diabetes. So, why vaccination is important? Diabetic patient, as we all know, it has got weakened immune response. That is because of the suppression of cytokine production, defects in phagocytosis, dysfunction of immune cells, and a failure to kill the microorganisms. And let us see at the diabetes with risk of infections. And these patients with diabetes, they have got higher risk for bacterial and viral. I think this is not coming properly. I think. Please come. Please come. Because it is coming, it is not. Yes. So it has got higher risk for bacterial and viral infections, and most of the infections are vaccine preventable. And we know that in patients with diabetes, especially in places like India, the lower respiratory infections accounts for many deaths, and it is the third leading cause of death. And diabetes, even if it is well managed, can make it harder for immune system to fight infections as compared to people without diabetes. And some infections like influenza, it is not only with influenza, but most of the infections, it will increase the blood sugar level to much higher level, and then it will make it very difficult for the diabetologists or physicians to control the blood sugar when there is infection. And in patients of diabetes, hepatitis B outbreaks has been seen. This may not be very much evident now because of the use of disposable syringes, needles, but in those other corners or outer corners of the country, still sharing of the needles may be continued, and so the hepatitis B outbreaks may be seen. And people with diabetes are at increased risk of death from pneumonia, bacteremia, and meningitis. And immunization provides a very good protection against vaccine-preventable diseases. Let us see the status of immunization in diabetes. Say only 1.3% of diabetes in India are aware of vaccination. That means more than 90% are not aware of vaccination. And these are the sources. The role of physician in teaching diabetics about the importance of vaccination is very low. So why the vaccination rate is very low in patients with diabetes? As I have said, that there is lack of awareness, limited healthcare access, and that also not all the patients go for treatment, and then like when they are not given proper advice, then they will not know there is called vaccination in diabetes. And the course of the vaccine is also a concern. Say even pneumococcal vaccines, it's more than 1,000, and if we think of influenza vaccine, it is very expensive. Hepatitis, very expensive. And the focus on childhood vaccination, as we are seeing the government sector, most of the government organizations are focusing on the childhood vaccination, but it is lacking in the adults, especially so in diabetes. There are cultural and social barriers, lack of physician advocacy. Not knowingly, many of us are not giving time for the prevention of diabetes progression and also complications. We treat, most of the physicians, most of the diabetologists or endocrinologists, we treat the disease, but we usually don't go beyond for other preventive measures. And so there is health system gaps. What are the vaccines which can be used in diabetes? The hepatitis B vaccine, DDAP vaccine, pneumococcal vaccine, herpes zoster vaccine, flu vaccine, COVID vaccine, and then respiratory syncytial virus vaccine, RSV vaccine. These are the associations or bodies giving vaccination to patients with diabetes. There are well-defined guidelines for vaccination in diabetes. RSSDI, we are in this, and API in our country. Let us go to pneumococcal infections in diabetes patients. So the risk of death due to pneumonia-related complications in diabetes is about 3 times higher than those persons without diabetes. Type 1 diabetes and type 2 diabetes have a 4.4 and a 1.2-fold risk of pneumonia-related hospitalizations. And if we see the hemoglobin, if the blood sugar is not controlled when the hemoglobin A1C is more than 9%, then there is 60% increased risk of pneumonia related hospitalization. And those diabetes who are well controlled when the hemoglobin is less than 7%, they also have another 22% increase in the complications when compared with non-diabetic subjects. So we have got two important vaccines. There are many other vaccines, but two vaccines are usually we use here in India. One is 23-valent pneumococcal polysaccharide vaccine, PPSV23, and the 13-valent pneumococcal conjugate vaccine, that is PCV13. Secondary immune response is higher with PCV13, whereas the response is lower with PPSV23. And for the age group 19 to 64 years, if the PCV13 is taken previously, it should be followed with PPSV23. And for adults above 65 years, PCV13 followed by PPSV23 1 year later. And PPSV23 should not be followed by another PPSV after 1 year. And if we need to give vaccination, then we can give this vaccine after 5 years. And influenza. People with diabetes are 6 times more likely to be hospitalized during an influenza epidemic, and the mortality varying between 5% and 15%. Influenza vaccination in people with diabetes has been found to significantly reduce the influenza and the diabetes-related hospital admissions. In all patients with diabetes, excluding those allergic to eggs and chicken, influenza vaccine is recommended. This is the slide showing Indian consensus guidelines on immunization, and then here also in RSSDI and pointer in RSSDI API, it is 1 dose yearly is given. And adults who have not received the vaccine should continue to receive it throughout the entire influenza season, especially during the times when the virus is active in the neighborhood, for example, before the monsoon season in South India or before the winter season in Northern India. And hepatitis B, people with diabetes are, as I have explained earlier also a little bit, are at a 2 times increased risk of infection by hepatitis B virus than the non-diabetics. So exposure to needle, then blood glucose monitoring frequently when there is sharing of the needles, then say inadequate handling of the machines that can give rise to hepatitis B infection in the diabetics. And so here we usually give 3 doses. And so these 3 doses at an interval of 1, 0, 1 and 6 months. So when there is travel to one very endemic areas, even hepatitis A also can be, hepatitis A vaccination also can be done. And there is another infection, herpes zoster. Herpes zoster infection, say it is very painful condition, especially in the diabetes and especially in the old age, elderly age. Say the complication of post-herpetic neuralgia is very difficult to treat in elderly patients, and one very the debilitating condition which can occur after herpes zoster infection is herpes zoster ophthalmicus. And then 2 doses of herpes zoster vaccine is given 2 to 6 months apart for all above the age of 50 years. This is by RSSDI and also by the API. And then here, this is the treatment, the schedule of herpes zoster. In this one, just this 1 minute. Okay. Some other vaccines which influenza I have said, TDAP vaccine, that is tetanus, diphtheria, and then pertussis. This also we, although we don't use, but we can use after as booster dose after every 10 years, and then COVID-19 vaccine also should be given yearly. These are some of the vaccinations given in India and in patients with diabetes. This is vaccination in this one by ADA recommendation. This one is also ADA recommendation for vaccination in diabetes. So, in summarizing, vaccination is a simple and effective way to prevent infection for individuals with diabetes. Increasing awareness among patients and healthcare providers is very much required. Inclusion of adult vaccine in national immunization program should be encouraged, should be introduced, and we should make the vaccines and vaccines affordable so that these patients can get vaccine properly in time. Thank you. Thank you for your listening.
Thank you, Professor Taruni, for your excellent talk, a nice deliberation on the need and the importance of vaccination in the management of diabetes. The question and answer session will be in the last part of the session. I call upon the next speaker, Dr. Sumitra Lystrom. She will speak on the recent trend and update on the management of the dyslipidemia. Dr. Sumitra, she is a consulting cardiologist and assistant professor in the Department of Cardiology. She is a hospital in the Research Institute. She is a leading, in fact, physician in the treatment of the field of the cardiology, also as an interventionist. Dr. Sumitra, please.
Good afternoon, respected chairpersons and ladies and gentlemen. Today I'll be talking on the dyslipidemia and recent trends. As we know, dyslipidemia is a very important component of the metabolic syndrome, and along with diabetes and hypertension is a major contributor to cardiovascular disease. And as we all know, most of the diabetic patients with or without kidney disease are ultimately going to die of cardiovascular disease. So this is the latest study which showed that there is around 82% of Indian patients suffer from dyslipidemia, rural around 80%, around 83% in the urban area, male 75% and female around almost 90%. This is the disease burden that we face now. And dyslipidemia in Indians, as we all know, is different from the Western population in terms of we have a higher prevalence of high LDL, low HDL and high triglycerides. And we also have a higher likelihood of increased lipoprotein small a and high levels of ApoB, which has a significant contribute to the ASCVD burden. And Indian population, as Southeast Asian population as such, is considered one of the high-risk ethnic group for the development of atherosclerotic cardiovascular disease. We know our patients develop cardiovascular disease earlier and in a much earlier age, and the burden is much more than that of the Western population. So dyslipidemia, especially LDL, low-density lipoprotein, is an independent risk factors for ASCVD. According to the AAC and the ACE, at the age of 40, lifetime risks of cardiovascular disease increase with higher cholesterol level. So with each unit increase in LDL, there is a 21% increased risk of cardiovascular disease, almost 50% increased risk in all-cause mortality, and 27% increased risk of a composite of CVD mortality. So there are different recommendations, as we know, the American Heart Association ACC recommendation, the European recommendation, we also have the Indian recommendation. Slightly busy slide, but they all say that we should have a proper risk assessment and with clinical assessment, and we have the different scores, the PCA scores, the ACC, American use the PCA score, while the European use the score system. So according to the whether the patient is in the low risk group, in the moderate risk group, or in the high risk group, these are the various treatment, the lifestyle modifications. Then cornerstone is statin therapy in both the guidelines. Then follow-up. Then in the low risk group, we target to reduce the LDL cholesterol by 30 to 49% from the baseline level, or in the higher risk group, more than 50%. And in a very high risk group where there is patient has severe hypercholesterolemia or clinical ASCVD, we want to keep the LDL cholesterol, American say less than 100, and very high, extremely risk group less than 70. Then if we are not able to achieve this with statins, then we have to assess the adherence, then we add the other lipid lowering therapies like ezetimibe and the PCSK9 inhibitors. Similarly, slightly different values with the Europeans, but ultimately the same basic. We want to reduce very high risk LDL by at least 50% from the baseline and the absolute value of less than 55. Then high risk group less than 70, moderate less than 70, low risk group less than 115. That is the target, in whatever means that we use to achieve. Now coming to the Indian recommendation, this is for the Lipid Association of India. It's because we have more high risk, we are of more higher risk ethnicity. Lipid Association of India recommends a much tighter lipid control. So in the patients are divided into low risk, moderate risk, high risk, very high risk, extremely high risk group, which will be category A and category B. So extremely high risk category A, the recommended range is LDL less than 30, and the non-HDL cholesterol less than 80, and we should consider treatment with the lipid level of the patient is more than these values. Then extreme risk group also, and a very high risk group, the recommendation is LDL less than 50. Very high risk group less than 70, moderate risk less than 100, and low risk patient we may consider up to, that also recommendation is less than 100 women and if we start treatment, if the LDL level is more than 130. Then how do we risk stratify the patients? So these are the patient has a measured risk factors, CVD risk factors, like age more than 45 or in males and more than 55 in males, in females. Current smoking, it's very difficult to say. High, low HDL level. Family history of ASCVD and high blood pressure or low HDL, these are the risk markers for major ASCVD factors. Then other high risk factors, diabetes with one or one or more major risk ASCVD risk factors, and no evidence of target organ damage. CKD stage 3B or 4, familial hypercholesterolemia, extreme of a single risk factors. Then if the coronary calcium go in the CT angio is more than 300 hospital units, non-stenotic carotid plaque or lipoprotein A, small a level more than 50. These are also considered as risk factors. Then we have some moderate risk non-conventional factors like coronary calcium of 100 to 99, increased carotid intimal wall thickness, lipoprotein small a 20 to 49, impaired fasting glucose, increased waist circumference, ApoB level more than 110, or HRCRP level more than 2. So patients who have 0 or 1 measured ASCVD risk factor and lifetime CVD risk less than 30% are considered low risk. Those with 2 measured ASCVD risk factors and low risk group with 1 or more moderate risk non-conventional risk factors, they have with a lifetime CVD risk of more than 30%, they are considered moderate risk. High risk patient, 3 or more measured ASCVD risk factors, 2 measured ASCVD risk factors along with 1 or more moderate non-conventional risk factors, or more than one other high risk factors. These are very high risk. Then very high risk patients, pre-existing ASCVD. Patient already had a coronary event or a stroke or a peripheral artery disease, diabetes with 2 or more other major ASCVD risk factors or evidence of target organ damage. They ultimately go into the very high risk group, and patient with familial homozygous hypercholesterolemia. Then extreme risk category A, coronary artery disease with more than 1 or more feature of high risk group, they are the extreme risk category A. Then extreme risk category B are patients with coronary artery disease with 1 or more features of very high risk group or recurrent ACS within 1 year despite LDL less than 50. Or patient has polyvascular disease, multiple areas in the brain, the heart, or in the peripheral arteries. So these are considered the very high risk groups. I think I'll just leave this slide. So management for dyslipidemia, statins remain the cornerstone. As we know, statin is a HMG CoA reductase inhibitor, which is the limiting step of cholesterol metabolism. And statin remains a cornerstone because other than reducing the number of LDL, it also has pleiotropic effects, other pleiotropic effects, and it can reduce strokes, heart attacks, and peripheral vascular disease. And lowering of LDL cholesterol by about 1 millimole per liter with the standard statin regimes reduce 5-year incidence of major coronary events, revascularization, and ischemic strokes by about a fifth. And all-cause mortality was found to be reduced by 10% per 10 mole reduction of LDL cholesterol. So, so more intensive statin therapy produces 15% reduction in major vascular events, 13% reduction in coronary death or non-fatal myocardial infarction, 19% reduction in coronary revascularization, and 16% reduction in ischemic stroke. So this is the recommendation of LAI. So when we have optimal, if the patient has risk factor, diabetes, hypertension, so diabetes, hypertension patient should be on optimal management of the risk factors. Then lifestyle measures should always be reinforced and should be associated and should be incorporated in the management. Diet, regular exercise, weight reduction, quit smoking, alcohol reduction, along with high intensity statin. This is for very high risk group and extreme high risk group, and we start with high intensity statin. Then we measure the LDL level. If this at 3 to 4 weeks, if the LDL level is still more than 50, then we add ezetimibe. If the ezetimibe, in spite of adding ezetimibe, and we will check again at around 8 weeks, if this still not controlled, then we consider bempedoic acid or PCSK9 inhibitors, either the monoclonal antibodies or the siRNAs. So to reiterate again, in the very high risk group, the LDL group goal is less than 50, and in the extreme high risk group category A, less than 50, optional goal is less than 30, and in the extreme high risk category B group, the target of LDL is 30 or less, which is much lower than what we are treating practically now what we are seeing in this one. So the same, more or less the same recommendation in the American recommendation and the European combination also. So high intensity statin is included in all the measure guidelines for this lipidemia management. So what is high intensity statin therapy? What do you understand by high intensity? High intensity statin therapy is where the rosuvastatin is 20 to 40 and atorvastatin 40 to 80. These are the only two statins that is considered for high intensity and at this dose. So it lowers the LDL by more than 50%. Moderate intensity statin usually lowers LDL by 30 to 49%. And in this, the doses where we consider moderate intensity, rosuvastatin 5 to 10, atorvastatin 10 to 20, and we have the other statins, simvastatin, lovastatin, pravastatin. These are all the moderate to low intensity statins. Then low intensity, which lowers LDL by less than 30%, is simvastatin, lovastatin, pravastatin, and fluvastatin. Then for secondary prevention of ASCVD, where clinical ASCVD which includes acute coronary syndrome, history of myocardial infarction in the past, patient has stable or unstable angina or coronary or other arterial revascularization, history of stroke, transient ischemic attack or peripheral artery disease, which includes aortic aneurysm, all of atherosclerotic disease. All these diseases are considered clinical atherosclerotic cardiovascular disease. Then we have the primary prevention of ASCVD, so groups that benefit from high intensity statin therapy. For severe primary, if the LDL level is 190 or more, especially those with familial hypercholesterolemia, whether the patient has other risk factors or not, we have to go for high intensity statin in this group. Then in a diabetic patient with the age of 40 to 75 with a 10-year ASCVD risk of 7.5% or more with high risk diabetic features. High risk diabetic features means long duration diabetes, more than 10 years in type 2, more than 20 years in type 1, or patient has albuminuria, or with a EGFR less than 60, retinopathy, neuropathy, ankle brachial index less than 0.5. Means diabetes with complications where we have some target organ damage. These are considered as high risk diabetic features. They benefit from high intensity statin therapy. Then if the ASCVD risk is more than 20%, and if the major coronary calcium score in the CT angio is more than 300. So therapeutic options for these are all high risk patients. So high intensity statin is the first line of therapy. Then or can combine with ezetimibe as a second line option, or we can combine with moderate intensity statin if the patient is not able to tolerate high intensity statin. Then PCSK9 inhibitor option for ASCVD patients or with, who are not able to achieve the target with the previous combinations, or familial hypercholesterolemia patients who either cannot take statins or have inadequate LDL lowering despite the statin therapy. So, as I've just discussed now, despite administering high intensity statin, or statin with other lipid-lowering therapies, a notable proportion of patients may not be able to achieve the LDL targets. And in Indians, it is estimated that nearly 30% are not able to achieve the LDL target. So there is a sizable residual risk. And then we have statin intolerance. Clinical practice is less than 10%, but in some high-risk group, it may be around 20%. So, as I'm emphasizing again, statins are recommended as a first line. If the patient is not intolerant, statins is always the first line. But if they are not able to tolerate or not able to achieve, then statin monotherapy may not be adequate. So, in combination therapy for lipid management is a new recommendation in very high-risk CVD or extremely high-risk patient. So extremely high-risk patient usually start with statin plus ezetimibe plus PCSK9 targeted therapy. PCSK9 targeted therapy can either be the monoclonal antibodies or the siRNA therapy. And in the very high risk group, we can start with statin plus ezetimibe. Then we measure. If we achieve the target, then continue the therapy. If we are not able to achieve the target, then add PCSK9 or bempedoic acid. So coming to the discussion about the new molecule, ezetimibe. Ezetimibe inhibits the intestinal uptake of dietary and biliary cholesterol at this Niemann-Pick level. You can see this at the cellular uptake of the this one by acting on the Niemann-Pick C1 like protein without affecting the absorption of fat-soluble nutrients. So at the intestinal level, it reduces the uptake of cholesterol absorption. So ultimately, it leads to less reduction amount of cholesterol being delivered to the liver, and due to reduced cholesterol delivery, there is upgrade of LDL receptor expression in the cells, especially in the hepatocytes. So LDL receptors bind the LDL and take increase LDL but have variable effect on LDL cholesterol. results that they reduce major CVD events with patient with high triglycerides and low HDL level, but did not decrease total CVD or total mortality. Then this is the newer molecule that we have, the PCSK9 inhibitors. PCSK9 is an enzyme which degrades LDL receptors. So when more LDL receptors is reduced, the LDL level in the blood increase. So we have two types of PCSK9 inhibitors. We have the monoclonal antibodies, which are the evolocumab and the
First of all, I would like to congratulate POROMPAT for having and also taking the opportunity and the organizing committee make me a part of this. I will talking on how to manage it and this cardiovascular information. I'll start with a few slides on what is called and cardiovascular disease, followed by role of pain loss and cardiovascular disease. Finally, we are now the molecule Now, obesity is a chronic disease which increases hypertension. It causes dyslipidemia, PCOS, and very often it is associated with insulin resistance. And insulin resistance is the hallmark of type 2 diabetes mellitus. It is seen that very often diabetic patients are obese. And we had a session on this called diabesity. Patients with diabetes and obesity are called
are supposed to be suffering from diabetes and its complication. It is seen that about 88% of people at the time of diagnosis of diabetes are either overweight or have obesity. And also it is seen that in India, more than 75% of patients with type 2 diabetes have uncontrolled diabetes, with an HbA1c more than 7%. That means we are dealing with a dual epidemic of obese, uncontrolled diabetic patients. There are multiple risk factors for diabetes, as we know. Similarly, there are multiple risk factors for obesity as well. As we can see here, that some of these risk factors overlap, like physical inactivity, high blood glucose, age, genetic factors, etc. And presence of these risk factors in a patient who is obese as well as having type 2 diabetes mellitus increases the risk of cardiovascular disease. The pathophysiology of diabetes, obesity and cardiovascular disease is complex. There is crosstalk between these two entities. We know that type 2 diabetes mellitus is a state of systemic inflammation where there is increase in inflammatory markers like interleukins, TNF-alpha, interferons, there is insulin resistance, there is hyperglycemia. They all lead to endothelial dysfunction, reticular dysfunction, increased oxidative stress, which finally leads to increased atherosclerosis. Similarly, obesity is also a pro-inflammatory state where there is increase in chemokines. There is increase in free fatty acids leading to dyslipidemia. In obese people, the RAS is also activated, which causes hypertension. So together, if the person has diabetes as well as obesity, multiple factors can lead to increased cardiovascular disease. Now the interplay between obesity, diabetes and cardiovascular disease is termed the unholy trinity. We see that about 80% of people with diabetes have either obesity or are overweight. Similarly, about 31% of people who are obese have also diabetes. About 32% of type 2 diabetes mellitus patients have cardiovascular disease and about 29% of coronary artery disease patients have diabetes. And in more than 50% of patients of type 2 diabetes, the cause of death is usually a cardiovascular cause. More than 80% of coronary artery disease patients have either obesity or are overweight. So this shows that the obesity, diabetes and cardiovascular disease are so much interconnected. It has been seen that excess weight leads to increased diabetes-related healthcare costs. As the BMI increases, the direct cost of therapy also increases. So we come to the second part. When we treat weight reduction, when we target weight reduction early, it can disrupt the underlying pathophysiology of diabetes. It can reverse or slow the progression of disease itself. It promotes glycemic control and also it impacts the cardiometabolic risk factor. Thereby, there is prevention of micro and macrovascular complications. So we need to target weight loss very early in the course of the disease. Now, weight loss has been shown to reduce the risk of development of diabetes. For every 1 kilo weight reduction, there is reduced risk of diabetes by about 16%. Weight loss leads to good glycemic control. There is reduction in HbA1c and there is reduction in fasting blood glucose. In fact, greater is the weight loss, greater is the reduction in HbA1c and fasting blood glucose. In the diabetes remission clinical trial, where weight management program was compared with best practice care by guidelines, which was taken as the control, it was seen that the greater weight loss led to greater proportion of patients achieving and maintaining remission. And in fact, the odds of diabetes remission at 2 years for every 1 kilo weight loss is 1.25, which is very significant. Also, in the look ahead study, it was seen that weight loss of more than 10% in diabetic patients who are obese had a 21% lower risk of a composite outcome within 1 year. When the data was analyzed for 1 year's look-ahead study, it was seen that weight loss, it reduces the cardiovascular event by affecting the blood pressure. That means it lowers blood pressure, it lowers the triglycerides, there is improvement in HDL, and there is reduction in LDL. Loss of about 5% of body weight in the year following diabetes detection was associated with improvement in risk factors, and there was 48% lower hazards of CVD at 10 years. So we can see that greater the weight loss, greater is the improvement in overall health and complication. So more than 15% diabetes remission can occur, cardiovascular mortality can decrease, and so forth. Even 5% weight loss can improve hyperglycemia, they can have an impact on hypertension. Finally, I come to the last part, that is the molecule semaglutide. Now, semaglutide is available as both oral and subcutaneous form. I'll be talking on the oral formulation. Oral semaglutide has a 94% homology with GLP-1, native GLP-1, and its half-life is about 1 week. In this semaglutide molecule, there is substitution of amino acid 8, which gives its protection from DPP-4 lysis. And also there is substitution of amino acid at position 34. Also, there is a extra long chain fatty acid bound to the position 26. The semaglutide molecule is co-formulated with another molecule called the sodium hydroxybenzoyl amino caprylate, or SNAC in short. This SNAC molecule, it protects semaglutide from breakdown by gastric enzyme. In fact, it increases the pH around the semaglutide. It also allows semaglutide to be absorbed from stroma and promotes the absorption across the gastric epithelium. Oral semaglutide is the world's first and the only oral GLP-1 receptor agonist. Co-formulation with SNAC does not change the chemical structure of either this molecule, and neither semaglutide nor SNAC, so they maintain their distinct entities. There are numerous clinical trial programs with semaglutide. More than 11,000 patients have already been enrolled for the studies. More than 6,500 patients are already exposed to semaglutide. The pioneer program are the studies involving semaglutide. There are different pioneer programs, there are different studies from Pioneer 1 to Pioneer 8. Pioneer 1 to Pioneer 5 and Pioneer 8. In these studies, the primary outcome was HbA1c level at the end of 26 weeks in comparison to the baseline. And the secondary outcome was weight change at 26 weeks from the baseline. For Pioneer 6, which was an event-driven study, the primary outcome was occurrence of first major adverse cardiac event from the time of randomization. And for Pioneer 7, the primary endpoint was HbA1c less than 7% at 52 weeks. So these are different pioneer programs, and in various studies, semaglutide has been compared with other molecules like empagliflozin, sitagliptin, liraglutide, and also with insulin. And it was found that semaglutide reduces HbA1c very robustly, up to 1.5% HbA1 reduction has been seen. Also, semaglutide has shown very clinically relevant weight loss up to 5 kilos across various studies, and it is better than most of the present molecules. Another point to note is that there was a greater threefold loss of lean fat over lean body mass. So when the person loses weight, it is mainly its fat which is losing, which is good for his health. Semaglutide reduces body weight through basically appetite suppression. The total energy intake as well as the food consumptions are reduced with semaglutide as compared to placebo. And there is one more observation, that semaglutide reduces waist circumference, and we all know that waist circumference is itself an independent predictor for atherosclerotic CVD risk. Now we know that semaglutide is available both as an oral and subcutaneous formulation, but it has been seen that irrespective of the route of administration, the exposure-response relationship is similar for oral and subcutaneous semaglutide. So oral will work as good as a subcutaneous formulation. Now, semaglutide has very clearly shown cardiovascular safety with reduction in ACVD risk factors. The Pioneer 6, which is an event-driven study where more than 3,000 patients were enrolled, the patients who received 40 milligram of semaglutide were compared with patients who received placebo plus standard of care. And the primary endpoint was occurrence of major adverse cardiac event, and the study was continued till at least 122 event occurred. In fact, the study was continued for 1.3 years, and at the end of the study, it was seen that there was 21% reduced risk of major adverse cardiac events, which confirms its cardiovascular safety, and also it is non-inferior to placebo. A major benefit which has been seen is on plasma lipids as well as hypertension, which probably is giving the cardiovascular protection. Now let us come to some practical consideration on oral semaglutide. First, it is very good molecule and it robustly decreases the HbA1c. Second, it causes very clinically relevant weight loss through appetite suppression. Third, it is in oral formulation. So very often patients do not want to take injections. So at present all the GLP-1 receptor agonists are available as injectables. So this is an attractive molecule, oral formulation. Second, next, it has got proven cardiometabolic risk factor modification as shown by the Pioneer 6 study. It targets the cardiometabolic risk factors early in the course of the disease. And one important thing is that for renal or hepatic impairment, no dose adjustment is required. Hypoglycemia risk is also very low, and ideally it should be taken in empty stomach with 120 ml of water, and the patient should be advised not to take anything for next 30 minutes. So to conclude, I would say that semaglutide is a very potent molecule which targets the trinity of diabetes, obesity, and cardiovascular risk, and if possible can be used. Thank you. Thank you for your patience.
Thank you so much, Dr. Bipul Chaudhary, for your excellent deliberation on this very important molecule of oral semaglutide. With this, we close the session and open the question and answer session. Let me start the question and answer session by asking one simple question to Dr. Bipul. Semaglutide subcutaneous injection is well known and proven and studied in many of the studies as far as diabetic, non-diabetic, and even in the kidney diseases to prevent or retard the complications. So what is your opinion about is there any head-to-head trial of oral and subcutaneous semaglutide as far as the prevention or further complications of the diabetes and the cardiovascular or even the kidney diseases? Any head-to-head trial, oral and the subcutaneous semaglutide?
Oral and subcutaneous, sir?
Yeah.
No, sir. No, sir, not yet.
Not yet.
Oral and subcutaneous semaglutide has not been examined in head-to-head studies, but the studies mostly injectables are different, and mainly they concerned about weight loss. Apart from disease modification, the injectables nowadays, they say it is more, they're projecting it more as a weight loss agent.
Okay, thank you. So, for the rest of the questions from the floor, Dr. Taruni and Dr. Sumitra will be glad to clear any doubts during lunch hour. And with this, we end this session, and we thank the organizers for allowing Dr. Rajendra and me to chair this session. Thank you.
Yes, thank you very much, our respected chairperson, for chairing this session so effectively. And as we know, this is our last scientific session today and for the entire 29th conference. So before we end this scientific session, we'd like to take a moment to honor and felicitate our respected speaker and respected chairperson. First of all, we'd like to request Dr. Taruni, Madam, our speaker, to be on the stage, and to do the honor, we'd like to request Dr. Y. Iboton, our organizing chairman. And now we'd like to request our respected chairperson, Dr. L. Amarjit Singh. Thank you very much. And yes, next we have Dr. Rajendra Thanjam, DM Cardiologist, Professor and Head Department of Medicine, JNIMS. And also would like to request Dr. Shumidra Laisham, a paper presenter who presented paper on a topic, recent trends in the dyslipidemia management. Thank you very much, everyone. Now we come to one of the most awaited moments of this conference, the announcement of the winners for the free paper presentation and poster presentation. So ladies and gentlemen, Let's begin with the free paper presentation first. So the third prize of free paper presentation goes to Dr. Aju Achan Kunju. Ladies and gentlemen, please be on the stage. Dr. Aju Achan Kunju. And if I'm wrongly pronouncing, then please pardon me. So once again, we'd like to request our organizing chairman, sir, to do the honor of giving the prizes for this free paper presentation. Okay, from Caesar Hospital. Yeah, please be on the stage. And if I can join the prize, people end up with the Naruk Cherry. Third prize winner, Dr. Aju Achan Kunju from Caesar Hospitals. Congratulations. Thank you. And the second prize goes to Dr. Dayavati Shujana. Ladies and gentlemen, Dr. Dayavati Shujana, please be on the stage. Okay. From JNIMS Pathology, Dr. Dayavati Shujana. Ladies and gentlemen. And ladies and gentlemen, the winner, the first prize goes to Dr. Nandaibam Velinda. Ladies and gentlemen, Dr. Nandaibam Velinda from RIMS. Okay. First prize for free paper presentation of this 29th conference 2024. Dr. Nandaibam Belinda. Congratulations. And thank you so much, sir, for doing the honor. And Makhatarappa Mathangi competition, poster presentation, SCD awards in Natopuraba, Dr. Ketrimayum Achogusing Sarvahangachari. And yeah, moving on to the poster presentation, the third prize goes to Dr. Akash Aravind. Dr. Akash. Okay. Dr. Akash Aravind from Caesar Hospitals. Third prize winner of poster presentation. Congratulations. And the second prize goes to Dr. Tirupati from JNIMS. Ladies and gentlemen, second prize winner, Dr. Tirupati from JNIMS of the poster presentation. Congratulations, Dr. Tirupati. And ladies and gentlemen, the winner of this year's poster presentation, the first prize goes to Dr. Kazan Bhutia. Ladies and gentlemen, Dr. Kazan Bhutia, if we are not wrong, from Caesar Hospital. On behalf of Dr. Bhutia, please, anyone from Caesar Hospital, please receive the prize. Not from Caesar. Okay.
Okay.
Then JNIMS RIMS. Which one? Okay, so yeah, we will hand over the prize to him personally after the event. Thank you so much, sir. Anyone who knows Dr. Kanzang Bhutia? So it's not written here. Okay, yes. We will find him. We will go through all the papers. Yeah. We'd like to request once again all the winners of the paper presentation and poster presentation for a very quick photo session before the closing remarks by our organizing chairman. Once again, congratulations all the winners and yeah, to all the participants. Before we close this conference, we'd like to request our organizing chairman, Dr. Vaibodons, to propose the closing remark.
Sorry to interrupt. There is an announcement. I have contacted the central body of NEDS, Guwahati. Probable venue for next year NESCON is probably Guwahati people. Okay, that is the announcement is informed and given the venue for next year NESCON. So all the PGTs are requested to prepare for something related to poster or something else for presentations like this. If you go, then please contact us so that you be sponsored for NETSCON 2025 in Guwahati. Thank you so much. Rest is for Sir Ibaton, sir.
We have had a wonderful NESCON in spite of all the difficulties by the curfew and public disturbances. There were papers, 20 papers were presented, poster presentations were 11, and the number of speakers were 24, and out of which hybrid was 13 and the physical 11. And the total number of delegations were 96, faculty registration was 43, PGT registration was 19, spout administration was registration was 7. Altogether there were 273. And we have had a nice mixture of primary, secondary and tertiary aspects of diabetic management. and the different aspects of diabetes in various categories. Now I thank all the participants, all the delegates, all the speakers, all the chairpersons. I hope you have had a nice and a productive time during the conference. Now we'll go to the meeting.
Thank you very much, Dr. Y. Ipoton, sir, our organizing chairman, for that heartfelt closing remark. But ladies and gentlemen, before we finally close this year's conference, would like to take a very important session of this conference, the feedbacks from our organizing committee members and anyone who is willing to say and put forward some suggestions or comments about this conference or for like coming conference. So first of all, so we have patron members, Dr. A. Bijamani Singh, P. Narendra Singh, Dr. T.H. Premchand Singh, Dr. M. Kulachandra Singh, Organizing Chairman, we have Dr. Y. Buton Singh, Organizing Secretary, Dr. Khetrimiyum Achauba Singh, Treasurer, Dr. Salam Ranabir, Scientific Committee Chairperson, Dr. N.G. Taruni Devi, Convener, Dr. L. Ramesh Sharma, Dr. Konsam Bayana Devi, Reception Committee Chairperson, Dr. K.S. Lokeshwar Singh, Convener, Dr. N. Robinson Meete, Souvenir Committee Chairman, Dr. Santa Naudem, Convener, Dr. N. Sasikanta Singh, Cultural Committee Chairperson, Dr. Naran Prasad, Convener, Dr. Johnson Maibal, Catering Committee Chairperson, Dr. Khetrimiyum Virendra Singh, Convener, Dr. C.H. Arun Kumar Singh, Transport Chairperson, Dr. Robinson Ningsen, Convener, Dr. Mohammad Mustaq, Publicity Committee Chairperson, Dr. Guliba Potsambam, Convener, Dr. O. Buddha Charan Singh, and Conference Secretariat, Dr. Khetrimiyum Achauba Singh. Hairiba equity membersing Mayamasu lady, Aduga member Nataba Mayamasu, Lengshin to the Labia, Toba senior doctor Singh, Aduga faculty members Singh, students Mayamasu participate, Tawiri, Masid Handa Pantokriba conference, Asigi Matanga, Tabinimba, any feedbacks, suggestions, Yamna, Harauta Yamna, Loshin Jariduna, Mayamgi Maratagi, Tabinimba, Lairagadi, Amutang. Kuthanga Pirakuna states that Linkat Piraknabagi, Madugi, Nolukcha Wapum the Matamsari.
First goes to our senior faculties, chairperson.
Yeah. Yes.
I request Thamo Mani, radiologist, to be on the dais, and Dr. R.K. Jaisri, radiologist, to be on the dais, Dr. R.K. Banasri to be on the dais. Thank you.
Ahambasidi patron member in the Leviriba, Dr. M. Kulachandra Singh, Sagi, Mikey Degi, Hadagi conferences, Sigim Matanga, Sana, any Thambi, Nimba, feedback, suggestions, comments, Thambi Ramdabasa, request of Zuri.
Actually, I think this conference, while conducting this conference, we have faced many difficulties.
Yes.
Of course, particularly by the organizing secretary, Mr. Professor Dr. Achauba Singh. He has taken all these burdens, and while trying to conduct this program, he has taken so much burden, and he faced so many problems, but ultimately it has been conducted, I should say, successfully, although the attendance of the delegates is a little less. Because of the present situation, it is already expected. I hope in future we'll be able to conduct in a better way to avoid these situations. Thank you.
Thank you very much, sir. Community organizing chairman sir the last oina again another closing remark mong doina thamjarage aduna mathanda organizing secretary sir the gisu adagi conference gi matangda sir na kari even waitaba technical difficulties mayam amudi koi mayog nakre sir kitang thambiyo.
Thank you. Organization is not simple and easy in any way, and I have to look into many angles. Somehow we come to the end of this function. Thank you all the participants, helpers, and all the work done by many of my co-persons. Actually, it would have been more better than this had it been in the form of physical only. Now it is half-hearted now. I see it. Few people speaking from outside and taking difficulty in conducting with Mr. Deepak, computer person. And he has lots of difficulty in internet problem. I really feel that also, and I got all messages from many people that your conference is broken in between. I have to bear with the comments. More or less, I think Sir has already announced the registration and the presence in the field, in the auditorium is not very bad, I hope so. And anything wrong done by us, be pardoned. That is what I have to say, and I might have done many things to conduct a conference in a smooth way. I must have scolded many people, and that also, please bear with me, because I was trying to conduct this function smoothly. Thank you so much for all the efforts and supports given to me during this function. And I, for the last thing, I do give my due regards to my teachers. All the teachers who are present here and outside who are not able to present here, but I do give my due regards, number one. Number two, and the people outside Manipur who are actually my co-friends, then my godfather, godmother instructed me to do like this, and physically they are absent, and unfortunately also not present online even. So I give
give my regards to all the ma'ams and the madam, sirs outside. That's all I can say. I think more or less my presence of my teachers making the function quite successful. Thank you all. Thank you. Thank you.
Thank you very much, sir. Really, as you are acting like a father to everyone, and you have every right to scold anyone you want, as to make this conference a very big success. And thank you so much. Madam Yasiman, Scientific Committee Chairperson, Dr. N.G. Taruni Devi, Madam Musu, any feedback, suggestion, Madam Gi Saitagi, Thambiram Naba, Naluchari.
Thank you. In the very beginning, I thought, the conference will not be so not successful. And I think the perseverance of Dr. K.S.H. Achoba goes without saying. That is because of his perseverance and thinking that he will definitely do it. That is the main thing which has come to the success of this conference. And apart from that, all who are organizing the conference, I could see many of the members work really hard. Though I am the chairperson of the scientific committee, in the last moment also I was not able to be here because of my another engagement. And I would like to thank Dr. Diana also personally. She has done a very great job in supporting this scientific section of the conference very well. And all the others involved in the management of this conference has done their share of work really very well, in spite of all the difficulties and the shortcomings which we faced because of the present problems in Manipur. And I would like to congratulate everyone involved in the management of this conference. And I hope that there will be other conferences coming up later on also, and all the organization or members will be again doing better than this one also, though it is really very good. And all the academic, whatever I have attended today, it was really very good. It is not half-hearted thing as Dr. Azuma mentioned. It is half presence because of the situation. Here they cannot be present here, but they have joined fully, and there is half presence, not half-hearted. And so I congratulate you again and all the other members who have contributed in every way possible. Thank you.
Thank you very much, madam. Thank you very much for that heartful. I'd like to say it's a message to everyone, and thank you so much for encouraging everyone of this NEDSCON 2024. And madam, yes, madam ki feedback suggestion tangingayda Dr. Sumitra Laishamsu stage ta linkat pinabagi damakta organizing committee ki side tagi haibirigeduna madam su linkat pinagna banarunchari. And next we will hear from Dr. Mani T.H., Associate Professor, Radio Diagnosis.
Thank you. Actually, this NEDSCON 2024
because I was thinking in diabetes mellitus only we see microcytic hypochromic anemia, and many a times microcytic hypochromic anemia, whenever it comes, the first thing that comes to our mind is iron deficiency. If it is not iron deficiency, then I look at the that RBC count, and if it is increased, okay, this is hemoglobinopathy. If it is not hemoglobinopathy, then I'll go to endocrinology. Diabetes to nahi hai. So like that, but it never occurred to me that erythrocytosis can also occur in diabetes. That was a new learning, that thing that I have benefited. And another one, throughout the course of this particular conference, I have seen how the organizing secretary was going through, because all the tickets were purchased for all the speakers from outside the state, and afterwards, because of the recent event of unfortunate event, I should say, that occurred in the district of Jiribam, so many people have heard all the wrong things about Manipur, and I totally agree with that, because once I go out of IMPHAL, I will hear the worst, but when I come back to IMPHAL, I know it is something like what you call that type. So it has been blown out of proportion. So everyone was scared. So no one was willing to come, and all the tickets were cancelled. And then this hybrid mode, again, it has got pros and cons, as everyone knows. So all those technical glitches that happen, and it was very much expected, because our internet connectivity was shut down, because it was purposefully disconnected as a preventive measure by our government. That was not appreciated, even though we don't appreciate it, but we have to live with it. So it was reinstalled, and then it took, a lot of glitches. And I just want to quote one more occasion. As a quiz coordinator, we usually organize annual quiz of the hematology at different stages. We have college round, then institutional, then state round, then regional round, and ultimately we go to the national round. So in one of those incidents, what happened was that, we were conducting the quiz from here, from the very auditorium, and what happened is that we thought the answer was not shown, but all the participants were coming online. I think Dr. Anjali must be remembering it. All the participants were online, and unknowingly it was presented in the presenter mode. That means you can see what the next slide is coming up, So what we did, we put the question, next is the answer, okay? And without us knowing it, all the answer was shown, And ultimately, with after half a day's hard work, and one of our clinical hematologists has put all his 100% effort on it, but clinical glitches we cannot predict, and that quiz has to be aborted again, had to be conducted all over again. So that was, at every step we learn something or the other. So, and here also I have learned SLB something 2, that inhibitor. When he asked me the question, I was at a loss. I don't know even the name of the medicine, and then those are the things which we learn knowingly or unknowingly. I'm not going to forget. Okay, and then there are many things, flows or whatever in the organization, and then somehow having a hybrid mode usually delays the process. Usually we go behind schedule. We cannot finish it off on time. Yeah. That is very much expected. And I have, of course I'm not part of the organizing team, but but I feel I myself am, because since my
Yeah, ma'am, you are really your own. Yeah, that's exactly how you should feel. Yeah.
So that was it. So it was a great event, full day, 2 days of great academic extravaganza, I should say, that everyone has enjoyed, and my PGTs also have enjoyed. I think Rosanna has enjoyed it. You have got a prize, and she prepared only for 1 week, I think. And actually she doesn't deserve the praise anyway. But she has so much of hard work.
Yeah.
Thank you so much, everyone.
Thank you so much, ma'am. Yeah, the problem we faced since yesterday, there's not by like any human disturbances or anything. We really can't help, but yeah, our technical team did their best. Our technical team did their best, and we finally completed this conference very successfully. So without lagging behind any paper presentation or anything. So a big thanks to our technical team. And moving on, Madam Sumitra Dagisu, paper presenter, Mr. Saruk Singhali, Adiri Matang, Madam Nikitan, touched on the Nungayani, presenter Mayamgi, behalf the Oina Magatar.
First of all, I would like to thank the organizing committee for inviting me to present a paper in this prestigious conference, in spite of not being a diabetologist. I couldn't attend yesterday, but I attended the full day today. I think the topic that were chosen were very diverse and very interesting, which covers the wide range of topics associated with diabetes. And some technical glitches were there that we've discussed with, and we know the difficulties in this situation. But overall, I would say it was a very successful conference, and we hope for much better and successful conferences in the future also. Thank you.
Thank you so much. Madam Bayana Dagisu. Yeah. Madam Bayana se scientific committee ki convener oina organizing team the yawi bani aduna Madam Dagisu wapam khara ta jagadi wapam phara laina khanjai.
Thank you so much. I'll see the timing first. It's good afternoon. So good afternoon to everyone, to all the respected teachers and whoever present in the hall. So first of all, I would like to thank Achoba sir for giving me the opportunity to be the part of the organizing committee. Actually, I passed out from PGI Chandigarh 6 months back. So before passing out only, Achoba sir called me up when I was still in PGI to be a part of the organizing committee. So at that time itself, I said yes, why not? So now after this is the first time I'm being a part of this Northeast Endocrine Society, and this is the first conference I've attended, though it's a 29. So it's an honor to be a part of this. And I'd like to thank everyone. And then as a convener for the scientific committee, I was given the chance to make the list and everything. So I prepared all the possible topics, and all the presenters and all the chairperson who has been a part of the scientific committee. I am very thankful, and I feel that all the presenters have done the justice to the topic. So I am very much happy that the scientific session was successful. Though it was done as a hybrid mode, I know there are so many glitches in the presentation, and we feel very sorry for that. But still, after all, everything is over, and I feel like it's a success. And so the next conference also, I feel we'll make, whenever we organize this conference in Manipur next time, I think we'll do more work. And then Madam Panasri has given one more this like this next time we think that we'll make quiz competition as one of the part of NEDSCOM. So I would like to be a this one. I'd like to organize that. Yes. Yes, sure. So that it can be more. So this quiz competition will maybe a nice option. So I think that next time we'll we'll add this session also. So thank you very much, and then thank you very much for the active participation. And I'd like to request whoever present out there, like my respected juniors, and then consultant, like whoever had any feedback.
People, presenters in the Maraktagi Natragana, PG students saying, aduga anyone present here, any feedbacks and comments. So in a Lerangani Hana Dikale, Wadli, Sidakara Sebu Hanini, Karahena, Matangi Silapamatamda, Hena, Pazana Silhaningi Haiba, any feedbacks and comments? Okay.
Thank you very much, sir. Such a pleasure to attend such a conference. Everything is, every deliberations, they are good, very nice, beyond the expectation of our beliefs. But one thing that I feel a little bit sorry is about the online deliberations. This is not good. Whatever they are talking, we are not able to grasp to the fullest. This is something that I would like to expect a better improvement in the future.
Thank you so much, Doctor. Thank you. Yeah, Madhumadi, Akari side, and the key one that you, what are the Bayadrihaga, Tamjari, Kitan, like issues say, Kalmaina, moment to the Kamina, Handle Togani or Kobo Togani, Haibu, the Kitan one at Hokrimadu, the Makta, what will be the number so high, and yes, for someone like outside of this institution and not related with this medical profession, I would like to say something with the permission of our respected organizing members on the dais. So actually, my background is dance. I think you won't believe, but I am a dancer. So yeah, my name is Priyalakshmi Lampam, and presently I am a news anchor at ISTV News, English news anchor, and a program presenter at Akashvani IMPHAL, All India Radio, and also a guest interviewer at Doordarshan Kendra IMPHAL. So, mayamna hainaba akoi performance in the ikaiba khangde haibado haigadra or akoi extrovert oi haigadra akoi gi sumaina akoi gi su workshop na chingba mayam ama tawe aduda student when participate tawba artist when participate tawba matamda akoi gi participation se chang yamna wangi haiba tare adu ngarang dagi su ai yawini hobudagi lobe fawba mamang da su conference amani sumaina medical gi field sida leiba conference amani ai participate tawgre aduda profession da doctor roina leiraba sing ana laing bagi lam sida yamna khumang yamna changsil laba singi side dagi participation se dum wangi ba makon masa expert ni they have questions. But sorry to say, from the students, Hosik Tammi Mayam Sigi Maratiki participation say young widely, and I really don't know why. Hiding around the Ringasipo with the Toriba Mayam, see the high river, Nam river Mayam, see the light the young river, Tinga river, come river points, areas Mayama Mayam Gani Kaliba. But why? Ikai Bagi High Gadra, Latagana Karigino Makoi side, I don't discussion with about the floors were open to me, but not a single student, not a single PG questionable raised of Deva. I really don't know why. I think this conference is for you all, especially. Now, for the priority, peer was in behind. but your participation is very poor, and I'm sorry, I'm not an expert. Haven't we talked to Bini? Although, yeah, I don't feel good about this at all. So please, next time, the any field the area the not the basigumba jago gida oigera, any cinema drama gida oigera, conference workshop if you have given any chance to ask something, then please feel free to ask anything about culture, about literature. Just doctor line yeah. So anyone from like in this house, please raise. I really want just a single, just one line feedback from you. So anyone, please. So this is not a good sign, as I've already told you, your participation is very important, not only inside the class. Anywhere you go, if you have any doubt, any confusion, and I surely think that you have confusion and you have doubts, but still you don't have, like, put up your courage together to stand up and raise your queries and questions. So, yeah, okay, sir.
Such a nice compliment from Priya Lakshmi. If I have to talk after you, it's not enough, because my voice is something, and as compared to you, and that's why when I just saw you during ILS conference, I just I was asking, who is this girl? Are you a part of ILDS Dr. Suras or somebody else? No, I asked. Then I came to know that you are something. No, this is, I'm not just talking exaggerating, but you are so good.
Thank you, sir. Thank you.
You are so good. And we are too happy, and we are very fortunate that a girl like you is among you. Because whatever I do, I speak medicine. This is not enough at all. I speak because I stopped speaking in front of the on the dais, because I had something deficiency in myself. That is not there with you. You are so confident. You are so confident. I tried, but I failed. But you are so confident. So we are too fortunate, and your comments given to the students is quite clear and known. And that's what the chairpersons were inviting questions from the students.
Yeah.
Could be that it's a conference of not their field, and could be that they are afraid of the teachers sitting here. Could be inhibitions. So lots of things are happening here. Could be they are not very feeling free to express their expressions. So that it's a feedback from your side, and nicely noted and kept within ourselves, and it will be encouraged. So last of all, but I really appreciate your presence.
Thank you.
And it is a very nice, smooth conduction of our conference throughout. So next time also, I think if you are not, so I am fortunate once again that if I had to conduct my scheduled conference, you would have been absent, right?
Yeah.
You were not free. So God has given me you as the anchor of this conference, because it was postponed. So another feedback from my side, right?
Yes, sir.
Okay. Thank you so much, Lakshmi.
Thank you, sir.
All the best.
Means a lot. Means a lot. Thank you, sir.
Thank you.
Loshira Poina, Chairman, sir, Dr. Y. Budondegi, sir, Sagi feedback, Sagi comments, Nuaiba Nuaita, Bahindaki conference, Gimatanda, Wapam Karadam Tambinava, Sardan Oluchel.
I think whatever has to be said has been said by everybody.
Yes.
Anyway, the only thing is, I thank all of you, all the faculties, all the speakers, all the delegates, all the students, everybody for making this function a success and keeping the banners of Northeastern Diabetes Society flying high. So, thank you very much.
Thank you. Thank you so much, sir. So, ladies and gentlemen, before we conclude, I would like to extend a heartfelt thank you to everyone who joined us both online and offline for this year's 29th Annual Conference of NEDSCON 2024. Your participation, enthusiasm and support have truly made this event a great success. As we wrap up, we look forward to welcoming you all again next year with hopes of making the event even grander and more successful. Thank you once again for joining us, and Pumnamapu Kurumjari wish you all a great day and a great time ahead. Kurumjari.